according to Apple. It's 11 o'clock, so Apple, I think, trumps it. Well, sorry, I shouldn't be using that terminology. It makes my blood boil. Anyway, I've been prone to tangents, but hopefully mine won't go into some really insane places and the dark recesses of one's bizarre mind. So anyway, I want to welcome all of you to it's not really, well, let's call it the maiden voyage of interview season 24-25 for the great and powerful Mount Sinai Department of Anesthesiology. If you're interviewing for peds or ortho or derm, you're on the wrong place or the wrong link. And you'd also be picking really poorly for yourselves. You guys couldn't have picked any better for yourselves, for your careers, and I applaud all of you. I have recognized now that this might be my 30, maybe 31st year I've been interviewing students for anesthesiology. And I honestly can't get any more excited, A, about presenting our program to you guys, and B, seeing all the amazing students that are choosing anesthesiology as a career. And I guess C or D, it's the best decision I have ever made in my life to choose this as a specialty and to have chosen Mount Sinai to be the place I became an anesthesiologist and the place that I became really passionate about the specialty, and about fostering, mentoring, and educating the future anesthesiologists. And I'm absolutely convinced you can't find a better place to become an anesthesiologist. I'm a little biased. I admit it. That's okay. I can be biased. But I've been running the residency since 96, and I wouldn't have given it up for a moment. I wouldn't have changed a thing. And quite honestly, through all of these series of presentations today, the interview process, the optional in-person, the virtual happy hours, all of the things, we're hoping to provide you the insight, the resources, the opportunities to make a very, very, very critical decision for yourselves. And I can't understate how critical this decision is. Now, you thought you made all of life's grandest decision about choosing anesthesiology. In fact, the majority of you didn't choose to go to medical school knowing you wanted to be an anesthesiologist. Even children of anesthesiologists don't choose. In fact, they absolutely fight the tendency. But lo and behold, through very different experiences, walks of life, interests, desires, passions, and career trajectories, you have all landed at the same place and time, looking at trying to figure out where's the best place for my career. And like I said, it seems kind of overwhelming to choose anesthesiology given the fact that anesthesiology might not have even been on your radar. But as you progressed through your clerkships and medical school, etc., you recognized that the things that drove you to medical school were embedded within a specialty that you knew very little about. And now you could see that the whole reason the alleviation of pain, suffering, anxiety is embedded in our specialty. And then you realized, as I did, as I joked, I liked getting my money's worth. So I loved finding a specialty that every single day I get to apply the things I learned in anatomy and physiology and pharmacology. In the first couple of years, I know medical school has morphed into this blended, there's not this bifurcated basic science to applied and clinical medicine, although that was certainly how I learned. And to this day, a lot of my educational motivation is to get people to recognize that you got to be scientists. You have to have a good grounding in basic science principles as it applies to clinical medicine. I also recognized, and much like you, most people don't choose anesthesiology because of omission, it's because of commission. It's not like, ooh, that sucked, that was terrible, this was awful, that's really stunk. It was like, oh, I like this, I like that, I like this, I like that, and wait a second, there's a this, I didn't even know that this was a that. And it becomes an amalgam. And you end up using all of the skills, the resources, etc. But now you have a blended specialty that is cognitively driven, but you got to have the goods to pony up the procedural basis to perform the tasks and skills because you're self-sufficient. And this really does take a lot of skill, knowledge, and abilities, and a very broad patient knowledge base to pull it off. I'm not going to pull any punches. It takes a lot of work to be a superb anesthesiologist. Anyone that wants to trumpet the fact that they get you out early, or you don't do call, or we have this, or we have this, or we get you, run for your lives. Unless that's the anesthesiologist you want to become, my guess is it isn't. I think these people are really short-sighted. I think they think that not working hard promotes wellness. I think becoming superb anesthesiologist is not counter to wellness. It's incapable of, you are incapable of being well as an anesthesiologist if you're not capable of managing any case that comes down the pike. You want to feel unwell, as I make it very blunt, suck. You want to find a place that's passionate about providing you the resources, the opportunities, and the skills, the knowledge, the abilities, and the mentorship to not only be amazing anesthesiologists, but amazing anesthesiologists who have amazing careers, who happen to also do other things with their lives. You've probably recognized that what has driven you to this amazing specialty is that people are multifaceted, whether it's they are interested in doing things inside the hospital in their work domain, whether it's administrative expertise, research expertise, educational expertise, mentorship expertise, or they're just interesting people who not only are passionate about being amazing doctors, but are also passionate about a lot of other things. And all of you have those passions. And it would be ridiculous that all of you had the same career trajectories. That would be foolhardy too. What you're going to hear over the course of all of these presentations is how we've built a program that's predicated on the idea that you are all individuals and that this program is yours. And it's a pick your own adventure, much like the interview season. The only required thing you got to do for your interview is come to the interview. The rest is up to you to satisfy your own interests, your own necessity, your own desires. But much like that, so too is the residency. We have a very unique residency that at our heart and core and soul, you're going to be absolutely amazing clinical anesthesiologists being able to care for anyone at any time independently. And I have to actually say that to the ACGM and the ABA. And the only reason I know I can say it is because I allow you guys to practice independently during your residency. But that is safe, well-structured, providing the resources, the opportunities so that you are safe, your patients are safe, the faculty is safe, and everyone is safe in the environment, but that you're going to be safe in your own skills. Imagine the first time you ever chose to induce and intubate someone on your own, or extubate is the very first time you're expected to as a faculty member somewhere. Oh my God, that's scary. Really actually kind of frightening. And being a superb clinical anesthesiologist is really paramount. And you'll see that the president of the hospital, the director of finance, the director of QI of the institution, the system, the chairman of the P&T committee, the program director, the assistant program directors, everybody at our heart and soul are absolutely amazing clinical anesthesiologists that will model that. And we don't choose to do these other things because we suck as anesthesiologists. No, that's our heart and soul. And in fact, that's the guarantee. But there are then opportunities that you will have, and maybe we don't even know them yet because you come to the table with unique skills, knowledge, abilities, interests that we can foster, knock down the barriers, and provide you the resources. We do have multiple scholarship-funded tracks, whether it's an education track, whether it's a research track, whether it's an innovative and entrepreneurial track, whether it's a DI track. Those are all opportunities that can provide you the non-clinical time, the resources, the mentorship, and the finances to really develop unique careers while you're also becoming superb clinical anesthesiologists. But without pulling punches, you have to be at your heart and soul as superb clinical anesthesiologists unapologetically. And that's sort of and the sort of the basis of the entire way this program is designed is based on the fact that I existed through it, and what I experienced, we've really kept modeling and developing and fostering. Much like you, even though we're generations apart, I'm pretty confident we had very similar experiences growing up as doctors. I'm a first generation physician. My dad didn't even graduate high school. He owned a hardware store. I couldn't even tell you if my mom graduated high school. The only reason my brother graduated high school and he was older than me was because he was a troublemaker and they wanted him out. My sister, lo and behold, she managed to get through high school. She tried college. It didn't go her way. So I'm the first college graduate. I'm the first person in my entire family that went to medical school. And I thought, because I had an aptitude for math and science, and I loved to sketch and draw, and I was very artistic. That was really my passion. And about fifth or sixth grade, I had the epiphany that I'm going to go to medical school and be a reconstructive surgeon. Ta-da! I could tell you, I absolutely loved medical school. I had the best mentors in the mentorship. My basic scientists, educators are still some of my most cherished memories from medical school. In fact, I was rewarded with the opportunity to co-write an article with one of our former residents, fellows and now faculty members, Patrick Mafucci, to write an article on how anatomy is used to teach anesthesiologists about the principles of different surgical manipulations and regional anesthetics, et cetera. And Jeff Laitman is still a staple at Mount Sinai as the professor of anatomy. And we got to write an article together, which is a source of pride. Well, lo and behold, I absolutely loved everything that medical school had to offer. I drank it up alive and I lived it, I breathed it, I loved it, and I marched through all of my clerkships, and I was not of the mind where, as I was on this, I was staring at that, and while I was on this, I was looking at that. No, I wanted, like I said, wanted my money's worth. So I was on peds, I was doing peds. When I was doing OB, I was looking at B, not looking over the drapes and seeing happy people. When I was on surgery, again, I wasn't looking over the drapes, and I did recognize that there were anesthesiologists everywhere, whether it was procedural, whether it was an emergency in the emergency room bay, whether it was in the ICUs. They were everywhere saving people's lives. Like, who are those masked people swooping in and swooping out? And then I was fortunate to have just selected a medical school that had a required experience in anesthesiology, and the epiphany hit that this is precisely the reason I wanted to go to medical school. I loved working with my hands, but I loved working with my brain. And I loved the blending of this specialty in one-on-one care. I mean, you listen, you guys. Oh, everything you wrote about anesthesiology personal statement is absolutely true. And again, it's really not changed over the no matter how people are reimbursed through insurance, which has completely obliterated some specialties where they have to keep things on a wrap meal. And anesthesiology has pretty much been grounded in patient-centric care from the beginning, which is what makes people so enamored by the specialty and why so many people choose to go into it. And you've recognized how virtuous it is to have superb communication skills and teamwork skills, and that it's very, very social. It's not isolating. And no matter how many times you've been told by very naive medical educators who probably didn't have anesthesiology, because probably only a quarter or a third of the medical schools in the whole country have anesthesiology. Oh, why would you want to go into a specialty where patients are asleep? As if patients aren't the only people we talk with and talk to. That's naive and really kind of silly. But more importantly, think about you and how you've encountered your patients in the perioperative period during that terrifying, stressful, anxiety-provoking environment where they're just meeting you and you have to rally up the support, the allegiance, have them respect you and want to embrace you as their caregiver, knowing that you're going to save their lives and really be focused on their care, while you're also formulating an anesthetic plan and stratifying the risks and the benefits and how you're going to satisfy those risks and benefits while you're also considering all the surgical manipulation. This is an awesome specialty. So I'm going to applaud you guys. You should give yourselves all a round of applause for joining in because it is amazing. Um, as I said, over the course of all these presentations, you're going to hear how this program is uniquely set up to focus in on, well, your care is patient-centric, our residency is resident-centric. And it really is important. And I will absolutely say, and this is without any pulling any punches, the anesthesiologist you become is where you become an anesthesiologist. I wouldn't trade places with any one of you. It's pretty daunting and, leap of faith to decide a place that's going to be completely influential on what kind of anesthesiologist you will become. If you just look back even just on a few short years, why are you even here? It's mentorship. It's modeling. It's the people you encountered. Find the place that speaks to you, that speaks to about how you learn, how you want to be taught, what are the resources, what are the opportunities, what is the modeling, what is the mentorship? Because just like most of you who came to medical school not even knowing anesthesiology was a thing, and lo and behold, you're sitting here interviewing for it, you have no idea what kind of anesthesiologist you're going to become and what other things you want to do with your specialty. You have ideas, and it's wonderful. And many of you have sort of hinted at, I want to be a cardiac anesthesiologist, I want to be a regionalist, or I want to be an OB anesthesiologist because you thought about OB going to medical school or a pediatrician. Now you could see pediatrics is really your pediatric anesthesia is really your calling. I got news for you. You're guessing. It's great to guess. Go in with an open mind, just like you did to medical school. And lo and behold, you might find yourself in a different place that you not couldn't have ever fathomed. I didn't go to medical school thinking I want to be an anesthesiologist and absolutely had no idea I was going to run a residency program, the longest running residency program director in the country for anesthesiology, I must say. Why am I doing this? Because I had the most amazing mentors when I was growing up as an anesthesiologist. My program director was amazing. My chairman, a guy named Joel Kaplan, if you Google that name, cardiac anesthesia comes up. Innovative guy. The reason why you put a V5 lead on people, Joel Kaplan. That's amazing. We had the first beta test simulator outside of University of Florida. Why? Joel Kaplan saw the vision of simulation before anyone even had an idea. There were just two places that were building them. Stanford and University of Florida. He challenged people. My program director and the vice chair of research at the time said, "Hey, build me a simulator. I want to test human performance." Light years ahead of anybody. We had the first installation of self-checking anesthesia machines. Imagine I had to convince students, oh, it's going to be okay. We had the first installation of computer record keeping and self-checking anesthesia machines. This is, again, the dark ages. But I had to tell students, oh, don't worry. Just because we have this latest technology doesn't mean you're not going to be able to learn how to practice in the real world. And then quickly, I just changed it. What you see here is your future. And that was dead on. Again, none of this would have happened if I didn't have the most amazing mentors. So find the place so this could happen to you. That's what the goals and objectives. Invariably, and we're going to have lots of details. Mark, Ben, I think Erica's going to join our APDs. Angela sends her apologies, but she just had her baby, and I think it's probably good that she should hang out. But we have 4 APDs. Before we dive in, everyone always says, hey, any major changes on the horizon? Like, oh yeah, I'm stepping down, or this is actually no. Sorry, Mark. um, um, I don't foresee, everything is an evolution and a constant assessment, improvement, and enrichment. There's not this upheaval, major change. Our president is our former chairman, David, joined us. When when my chairman, Joel Kaplan, came here, David showed up, and so did Andy Leibowitz, our chairman, and so did the director of medical school clerkship, Mike Chitera. And so this place has been an evolution. When David became the president of the hospital, probably now a decade, maybe even, yeah, about a decade ago, Andy was the executive vice chair, and he became the chairman. I became the executive vice chair. I've been running the residency program since 1996. What has sort of morphed, our program expanded our program to 120 residents. We went to 30 a year. We were approved last year. So the first 2 classes, our internship class and our current CA1 class, are 30. We're about to hit our 120. I'm accelerating the process a little bit, and so we're going to hit our 120 this coming July. So we will be one of the largest programs in the country. I don't want that to be daunting to you. No matter how big we are a long, distended, dysfunctional family that everyone knows everyone. It's sort of like Cheers. Everyone knows your name, and that is the fact, and it is a source of pride for this. So no matter how large we have expanded, and I'm absolutely convinced. I sit on the resident review committee, and we are approving many different programs. We're never going to do what emergency medicine did, but I'm convinced there are centers of excellence, and those centers of excellence should be expanded to meet the needs of our superb students going into anesthesiology, and that should be the focus. And so that is why we've expanded and we're also using that expansion to move into different environments and guarantee different environments. We've built an ambulatory surgery center that will have most of our regional has been turfed there. So that's going to be required. We've already had an office-based practice that used to be an elective. That's going to be a component of the requirement. And so with this expansion, we did that. We also enriched our interns class. We actually used to do 3 blocks. We call them, I guess they're 4 blocks because we have 13 blocks. We took 2 weeks away from surgery, 2 weeks of medicine, and built a perioperative medicine rotation for our interns while we were in the process of expanding. We might as well enrich that. And so people get 2 weeks of PAT, that's the preoperative assessment, and work with the faculty and the residents on preoperative assessments. They learn how to optimization and evaluation of the preoperative patient. And they also spend 2 weeks with the PACU and the PACU attendings, the team leader, CA3 resident, and the PAs. And I will tell you, that's sort of, Mark and I were like trying to figure out what to do because 30 doesn't go into 13, so it doesn't really matter. And we're like, I don't know, what are we going to do? And I'm like, oh, let's do this. And we just did it. And it's great. And the feedback has been really extraordinary. We've just sort of we've then another change is we added a scholarly. We've always had our clinical educator track, but Talia Scott, who is one of our residents, one of our teaching chiefs, she's an OB fellow, she's staying on his faculty, and Patrick Mafucci. Patrick is an MD PhD. He's really built a whole anatomy, cadaveric, virtual reality educational program for our residents and really the institution. They wanted to create a subdivision of the clinical educator track, which is a subdivision of research, and they'll be one of our students will be funded to do education-based research. We always had people do education-based research within the Eliasberg research. This will be an offset, and they'll also be given non-clinical time to attend IMSH, which is the major simulator meeting. I'll hook them up with attending the SEN, which is the Society in Education, the Simulation Education Network through the ASA. They'll also be able to go to the SEA, and so that will be an offshoot. And so, again, I can't emphasize enough that this is just an evolution. Talia and Patrick say, hey, can we do this? And I'm like, yeah, let's just do it. So it really becomes a very easy, process about evolving things. Patrick had a vision for his own education. He was the major head TA with Jeff Laitman in anatomy, even though he was an immunologist, MD PhD, from internship. We've supported him with cadavers and time off to continue his education. And now it is a critical component of not only our education, but a team-based educational activity with the surgeons and the residents. So ENT surgeons and ENT residents and airway residents will come together and do the airway. Liver surgeons and the liver residents and the liver transplant fellows will come together and work on liver and how, why the different surgical, how that has influence over the anesthetic considerations, et cetera. All the regional, he developed and worked with companies, developed fresh prep so that when you inject dye for regional blocks, you could track it down, you could do ultrasound on the cadavers and then see how your regional anesthetic techniques have worked and the tracking of dyes, et cetera. So and it's just, again, Patrick came with this vision. I provided him the resources and recognized the virtue and then got out of his way. And now it's just a critical component of a resident. It's a win-win-win. None of this is rocket science. But it really is empowering to the residents because you guys are not just here as replaceable 4-year cogs in a wheel so we don't have to be. No, you're our colleagues, which is why when you get in the line, I say, hey guys, and you're like, hey, Dr. Lee, and I'm like, no, 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 it's Adam. We both joined the club. You don't have to call me doctor. Um, it makes for a very collegial, it's not unprofessional, just very collegial and conducive to education and learning, etc. The other evolution that's happened at Mount Sinai is Mount Sinai just grows leaps and bounds like every other major institution. So we've like sucked up 8 other hospitals. We're one of the largest employers of people in the entire New York metropolitan area. We provide about 40% of all the care in the New York metropolitan area, which is absolutely extraordinary when you think that there's Cornell, Columbia, and NYU sitting in this domain, and Hofstra Northwell, which is a behemoth on Long Island. And so but with that, one could be frightened to think, oh, we're just going to be turfed to lots of places and we have to go here and there and everywhere. Absolutely not. We provide the anesthetic care over many different institutions you will never know exist. Why? Because they're not virtuous to your education. The only time we send a resident to a place that's for their to be there is for your education. And the only way we do it is we start as a model by doing an elective. If it gets great feedback, then we'll continue it as a major component for everybody. But one doesn't need to worry that with these rapid expansions of institutions, what's going to happen to the program? Nothing, unless it's virtuous to your education. Then we'll look at it, we'll see what kind of resources exist, and we'll find out what we're going to do about it because it might be something that will be kind of cool that we don't even know anything about yet. But we will look and take the feedback from the residents by offering it up as an elective. One amazing thing that actually has happened that has dramatically enriched our residency program, probably in the last 5, 6, 7 years, is with this expansion has been this consolidation. So, economy of scale is really important. And as opposed to having everything at every institution, no, what ended up happening was the PICUs in all the peripheral hospitals shut down. So all the very critical kids have shown up at our doorstep, and we have this massive explosion of pediatrics, and we've had this massive recruitment of pediatric anesthesiologists, and we've explored the opportunities. So not only did we have to include a week of pediatric simulation during boot camp and during the CA1 intro to anesthesiology, every CA1 gets PALS certified early in their CA1 so that they can obviously take care of the patients. Every CA1 gets a rotation in pediatrics, and then you get a senior, so you get early exposure to pediatrics. Then you get your second year, and then most people opt to do a subspecialty, whether it's INE, whether it's cardiac, whether it's regional, whatever. But those have rapidly expanded. And the feedback I've gotten from our pediatric anesthesiologists is pretty remarkable, is that the level of the cases that our residents get to do would naturally have gone to pediatric fellows. And so we don't have a pediatric fellowship. In fact, it's the only fellowship we don't offer because I'm still convinced that the best way to do a pediatric fellowship is to have an isolated pediatric hospital where you sort of have the opportunities. And I don't want a fellow to interfere with our residents' education. I can sit here today and say we have amazing we have 9 cardiac fellows. We have 2 liver transplant fellows. We have 7 or 8 pain fellows, 2 regional fellows, 2 orthopedic fellows. We have a simulator fellow. Translation. Our fellows enrich our residents' education. They don't take the cases away. They serve as junior faculty and support and service the resident education. So they get to learn how to supervise as junior faculty, and the residents get to do the cases. So at no place, no time, no area are having these fellows compromise our resident education, else we wouldn't have it. I'm also proud of all of the fellowships because our residents, even though with the job market on raging fire, more than the fires in Canada and out on the West or wherever they're raging these days in the rainforest, which is sad. Despite the raging on fire job market, or because of it, the opportunities for fellowships and the top fellowships are also available. Residents can hand pick where they want to do a fellowship, whether it's Boston Children's, whether it's CHOP, whether it's going down to do for cardiac or Mass General or Stanford or UC, anywhere. So the end result of becoming an anesthesiologist is so rich and so ripe, and I'm so excited for everyone because the job market's amazing, whether you want to choose to stay an academic, whether you choose to go into private practice, whether you choose a fellowship and then start looking for your job opportunities. It really is rich and ripe. And I'm proud to say that despite how rich the opportunities are for fellowships, many of our residents choose to stay at Sinai for their fellowships because they are really amazing. The joke sort of is we make really good faculty. We don't make very good fellows, especially when the residents go out to other places because we supervise. Our residents get more independence as residents than they experience as fellows when they go to other institutions. But I will reassure you, there's a fine line between embedment and empowerment, and we've never crossed it. During the intro to anesthesiology, the resources between the daily education, which doesn't matter whether it's July and August, there's daily education every single day of the year. And in fact, there's about 400 or 500 didactic hours, which you'll hear Dan Katz, our Vice Chair of Research, talk about and all the virtues of our didactic program. There's a simulation program. You can expect to get 50 to 60 hours of simulator time during your intro to anesthesiology as you make that critical transition from intern to anesthesiologist. There's one-on-one mentorship, and you'll have 3 full to sometimes 4 or 5 full blocks of non-specialized anesthesia that allows us to assign you to the broadest patient population surgical derangement anesthetic technique. We make your schedules every single day, whether it's the APDs, and on the rare occasion they want me to do it anymore, they're like, "We're on vacation. Can you handle it?" I'm like, I think I got this." But you have a voice at the table every single day. That's empowering. And many times the residents are like, "Hey, can I do X? Hey, can I do Y? Can I do?" Yeah, it's wonderful to have a say in your own education. Absolutely. We're only here to facilitate your education and you developing as the most amazing anesthesiologist and our colleagues, because many of our faculty, lo and behold, probably 85% of our faculty come from our residency. So we're not here sitting here interviewing you guys for 4 years of residency. No, it's a long-term relationship because that's what ends up happening. And even if you go elsewhere, which I sort of joke, the Sinai students know us and they sort of want to come, and I'm really proud of how many Sinai students. So none of my faculty that stay on are any good to me. I love when they go out and become mentors elsewhere and then bring in students from all the other. So I'm like, can you lazy people get out of here and go, be good role models to elsewhere, so you can draw some students in from other schools, jokingly. But sort of that's in store. Mark, Erica, and Ben are going to go over all the details of the specific rotations, the subspecialties, and what the graduates do. But as a broad sweeping overview, you can't find institutions that have more diversity in practice parameters, patient populations, and just sort of the decorum of the environment. So I'll give you an example. And quite honestly, like I said, the only reason you go to other institutions is to give you an education on the different practice models within the practice of anesthesiology and the delivery of care. Mount Sinai is a Courtney-based institution. We have 1,300 beds. We have, 12 different ICUs. We have about 80 different operating rooms. We do about 160 cases, 250 cases daily. We do about 8,000 deliveries, of which a third are high risk, maternal, fetal, or fetal. There's not a case that you will not see here at Mount Sinai. In fact, there's not a case or a requirement from the ACGME that isn't done here. In fact, all of the requirements can be done here and will be done here, and the majority of your requirements will be completed by the time you finish your second year. So the first and second year are you first do the intro to anesthesiology, then you do the subspecialties of anesthesiology, and then the majority of your third year is an elective time that provides you the opportunity to see things in more in-depth opportunities or do some subspecialties. To give an example, Amanda's one of our teaching chiefs. She wanted to be on the rapid response team, and she just came back. And we've wanted to do this as an elective. I have a little concern about the faculty not being exclusively anesthesiology, and her feedback is it's been extraordinary. So we are going to roll that into the residency. And as she said, she's gotten to do more POCUS and difficult airways and assessment of unstable patients in a very quick amount of time. And as she said, it's a 2-week rotation, and she's had a blast. And so we provided that. That was something she wanted to do. And so we'll roll that in. So those are the kind of opportunities. In the third year, a lot of people all on the scholarly tracks will have dedicated 6 months of dedicated research time if they want to use it. A lot of people use it broken up. Some people don't use it at all, use all of it, but it'll be the opportunity to do the capstone projects in the leadership and management or the DEI or the innovation and entrepreneurial or the research track or now the educational track. And you'll have those opportunities as well. In addition to Mount Sinai, and Mount Sinai, mind you, I'll probably go head to head with any other institution in the world. I can't imagine a more diverse, unique neighborhood as Mount Sinai. Many of you won't be able to come and see it, but if you do, Mount Sinai sits at 100th and 5th and Madison. On one side of the hospital are the projects. Spanish Harlem, highest incidence of asthma. On one short block, probably, I don't know, 150 paces due west, you land on Central Park, Fifth Avenue, Museum Mile, the conservatories on 105th Street, the Guggenheim's a couple blocks down, the Met's a couple down blocks that way, the Museum of New York City, the Jewish Museum. These are all within our neighborhood. We sit on Museum Mile. We straddle the richest of the richest and the poorest of the poor in our single neighborhood. It is the most diverse neighborhood you'll ever find. Unless you go to Elmhurst City Hospital, which is our level 1 trauma center. There you get 2 rotations, trauma anesthesia and basic anesthesia. And it is a level 1 trauma center. Elmhurst City Hospital, and I could say this without even pulling any punches, it is the most diverse patient population of any hospital in the entire world. I used to say only 80 dialects are being spoken at any one time. I think I've undersold it. I think there's 120. The demographic of the human population around Elmhurst City Hospital is the diverse human population of anywhere on the globe is sitting around that hospital, and you'll have access to that. Many people, you'll do your required rotations at a city hospital, so it is one of the Health and Hospital Corporation. City Hospital is one of the largest public hospital systems. It is the largest public hospital system in the country, which is the New York City Hospital Health Corporation, and it is one of those hospitals. And you get that virtue as well, caring for patients that don't have insurance and who are very very diverse. Add that to your rotation at our Bronx VA, so-called our VA. Here you have the sickest of patients, vascular disease, oncologic disease, prostate disease, thoracic disease, etc. And Dipali Dar is one of our former residents. She went to UCSF and did her pain management. And there's no fellows, so you get to do all the regional blocks and all the fluoroscopy and all the cases, and you get to work side by side. It's a regional spinal cord regional center for all the local VAs, so the patients with significant pain syndromes end up at our VA as well. You can also elect to do electives at Einer Infirmary, which is basically a surgery center for pediatric ENT, and it's an ENT position. You can also do an elective at what used to be Roosevelt, which is now West, which is an orthopedic hospital. The president of the hospital is a former orthopedic surgeon. Evan Flato does one of the world's renowned shoulder surgeons to represent the orthopedic nature of that surgery, of that environment. Meg Rosenblatt is our former director of regional anesthesia. She's the chairwoman there. One of our former residents is the program director there. It was the home of NYSORA, New York School for Regional Anesthesia. So if you ever Google that, that's where NYSORA really originated. You can do an elective there. Meg's claim to fame, she was the first one to report on the use of intralipid to treat a last patient, which then became almost protocolized and standardized in guidelines within 2 years. You can also do, between our office-based practice and our ambulatory center, there's not a practice model that you will not encounter here at Mount Sinai. Um, some high points in our in sort of our clinical, and again, Mark, Ben, and Erica will go over some of these. But to me, some of the true high points are transplant. There's not a single or hot organ that we don't transplant. Hearts, lungs, livers, kidneys, small bowels, pancreases. The small bowels and the livers go to the liver team. The pancreases and the kidneys go to the general OR team, and the hearts and the lungs go to the cardiac team. We're one of the busiest liver transplant centers. I think it was in the 200 range compared to any other institution. Maybe we're number one or number three in the entire country. What that tells you is that I think on average, our ASA status of almost all of our patients are somewhere in the high threes. You are going to see very, very complex patients, which is going to make you superb anesthesiologists. It's going to be commonplace to take care of really, really sick people undergoing some really invasive procedures. Um, our liver transplant service is some of the best anesthesiologists, given the fact that we have amazing anesthesiologists. That's a high bar, but many of them are our former chief residents. They're amazing role models, amazing women role models. They stay on, and we just have and we make a lot of liver transplant anesthesiologists because of the role models, and we always keep two, and several go out and learn transplant anesthesia in other environments. Our cardiac division, the only cardiac case you will not see in cardiac is a healthy person with healthy hearts and lungs. They just don't show up here. You have to have end-stage liver or end-stage heart disease, end-stage brain, kidney, liver, failing ventricles. They come off on multiple pressors and devices. You'll see it from off pumps to on pumps to everything in between, and minimally invasive and maximally invasive and circ arrests and everything. There's about 17 different operating rooms in cardiac between EP and invasive and non-invasive and endovascular and open heart within the cardiac division. ENT, I can't understate this. I don't, again, pull any punches. I've never intubated anyone with a video laryngoscope, and people are like, really? Why? And I'm like, because I've never needed to. And you should really ask. I'm hearing way too many, and I think this is the failure of our specialty by compromising your own skills, by using devices that are simpler and easier to use, and you'll never amount to being the top of your game in ENT. We have a very robust ENT department. From the massive head and neck revisions, we do, I don't know, probably 5 free flaps a week. You'll master bronchoscopy, you'll master awake intubations, you'll master regional anesthesia for the head and neck, and whether we're doing superficial cervical blocks for the surgery or for the postoperative pain, infraorbital sphenopalatines, or the superior laryngeal and recurrent laryngeal nerve blocks for the awake intubations, you will master all of that. Couple that with our invasive bronchoscopic suite, which I spend a lot of time on, and we will do the craziest cases in there with the most amazingly collegial, wonderful doctors who are our invasive pulmonologists who respect what we have to offer because it's doctors talking with doctors, and they are amazing. Our OB, as I mentioned, Jake Balin is one of the co-editors of the definitive textbook on OB. And he's our head of QI and the head of the institutional QI. And then, as I said, we do 8,000 deliveries, etc. I'm about to wind this down in the last 2 minutes and literally tell you, we welcome your interest in the program. We thank you for spending so much time getting to know us. Whatever we can do to alleviate any anxiety and fear and making sure that you're picking correctly for yourself, we're more than happy to provide those resources and the opportunities. So feel free. And we'll look forward to getting to meet you on your interview day, and we'll provide other opportunities. This is not a great forum for question answer, so we'll refrain from that. But when you guys come back for your interview, we've set away some time to just allow you to chat. We'll have an informal opportunity with myself and the APDs, and before the interviews and before you meet with the residents. So there will be plenty of opportunity for you guys to pick our brains and to be reassured that this is the right place for you. Because if it is, you really have, I mean, it's the rest of your careers and such an exciting career you have in front of you. And again, I welcome you and applaud you simultaneously. And with that, I've hit my stride, I've hit my number. I said I'd stay on time. I could wax and wane poetically,
You've
and I
got
used to
15
do.
seconds.
I
15
know.
seconds.
I used to do the full 3 hour tour myself in one breath. So now I've got lots of helpers. Now I can breathe, and I'll hand this off to Dan. Dan Katz is our vice chair of education, and I'm going to steal your show a little bit. Dan and told me that the reason he even chose Mount Sinai is because he saw this simulator lab at when he was interviewing for medical school one day, and this guy was in there and that was doing some stuff with the simulator and just did a dog and pony show impromptu, an impromptu dog and pony. He said, "Boy, oh boy, I want some of that." Well, not only did get some of that, he drank it like a fire hose, and we were fortunate enough to recruit Dan to the residency. He joined me as a third-year medical student on the ASA, and now he's our vice chair of education. He's a full professor in less than a decade, and he's everywhere. In fact, he's the president of the medical board, and he's on every educational board and has great resources, and is just an amazing member of our faculty. And so I will turn it over. I'm still 11:45.
Yeah, you're still
Got it.
good. You're still good. Um, Thank you so much for the introduction. It's nice to meet all of you. Again, my apologies in advance. You see, I'm on the labor floor. I'm clinical today. So I took over from Ben, who left us an amazing floor from the weekend. So thank you for that, Dr. Hires. So I know it says I'm supposed to talk about didactics, but honestly, I really want to spend the time talking about our educational program because yes, the didactics are like a cornerstone of it, but it really is such a small piece of what you're going to get at a place like Mount Sinai. I know that, Adam already mentioned the degree of training that you get here. I can't emphasize that enough. Again, this is a hardworking residency, but the training that you'll get here is bar none the best that I've ever seen any other people come out of. I can say, at least from my own personal experience, that I've never been in a situation where I didn't, I found myself out of sorts or something where it's like, oh my God, I've never seen that before or done that before. And that says a lot considering, again, the patient population, that we see. It speaks a lot to our program. Now, how do we do that? Now, obviously, a large part of it is doing the clinical cases, right? But obviously, that has to be supplemented by other educational materials, all right? And we do this a couple different ways, and we break it into a couple different sections, right? So we have a whole educational program, and for me, it's sort of it's a couple of main keystone elements, right? The first is we want to make sure that you have the training to be awesome, clinical anesthesiologists, and we spoke about that too. The other, main high point here is that we want to make sure that you have all the tools that you need to pass all of your exams. And I say exams meaning ITE exams, board exams, oral board exams, OSCE exams. I feel like every year I do this, I need to add another exam that you guys have to do. Now, and by and large, those two things are usually in concert. But again, if you're going to be studying for your basic exam, you got to learn the transporters of the tubules of the kidney. That's not going to be the most applicable thing, in the operating room necessarily, right? But, if you got a patient in volume overload and you're giving them a dose of Lasix, you really sort of have to understand how it works and why it works and what are the downstream ramifications of it. So as much as I bash the basic for being that sort of like an exam, it is important knowledge for you to know. But again, taken with a grain of salt. And those two things usually are in conjunction. Then we have this sort of like third pillar, which I call life education. We actually have a whole series of it this week. I'll show you guys when I show you the calculator, the calendar. But basically, that is the pillar of teaching you guys to be great people. And I don't mean like, personality wise, but answering some of those life questions that you guys may have, coming in, right? So we actually have, dedicated content to talk to you about things like, how do I pay off my loans? What is a good, tax strategy for saving my money? What is a Roth IRA? And is that something that I need to do? Do I need disability insurance? Do I need life insurance? Do I need supplemental life insurance? Do I need, an umbrella policy? These are the kinds of questions that we don't really get any sort of training on, as medical students, which sort of puts you guys at a really, really big disadvantage. And the reason why I've made this such a big, highlight of our program is because honestly, it's something that I wish I had had when I had come up through the come up through that sort of phase in my life, and I really had no idea, what I was doing. And as time has gone on, that sort of thing has always only gotten more complicated. PSLF, no PSLF, repay, pay. I mean, when I went through it, it was like it was IBR driven or not. And that was basically it. So you guys have a lot more choices and opportunities, but there are a lot more ramifications when it comes to your loan strategies. But again, that's now we're going like down a rabbit hole. So those are like the three pillars. Okay. So how do we do it? Well, we do start with a standardized, didactic schedule. And here, I'll show you guys sort of like what it means. Here, I think I have it on my. Can you guys see my screen? Yeah. So this is our intranet website that houses some of the material. I'll show you the real master plan thing behind it that drives a lot of this content. But on here, you have access to all the educational material that you might need, like links to the best journals and our emergency protocols, and access to new innovations and all that sort of stuff. But down here, you see our didactic calendar. So whenever we have lectures, if they're on Zoom, all you got to do is click a link here. If you're on a cardiac, you click a link here. And here you'll see the scheduling for all of our didactics. So you see this morning, this whole week, we have a series from a financial planner who comes to just talk about financial planning. Today at noon there's a cardiac resident lecture. Then from 3 to 4 there's a TEE. And then you can see, like, again, it goes through the days and what exactly is on the schedule. So typically Monday through Friday, there's going to be content that will be available for you guys to attend, either in person or on Zoom. The 6:30 lecture that we typically have in the morning is the best time to get everybody all together, in one place to sort of get, the highest yield education that we can. And the content will sort of vary depending on the time of year, right? We try to make because that time is so precious, we try to make it as efficient as possible for you guys, meaning that the content will rotate as the year goes on. So for example, when we first start in July, the idea is that we got to get everybody sort of up to speed, and we need to do a refresher for those who are more senior residents. So it's a really sort of like an anesthesia nuts and bolts lecture series that happens that usually winds up ending usually at the beginning of October. And then we sort of transition from there to do some more practical hands-on based skills training. So last week, I did a lecture on ultrasound guided paravertebral blocks and ultrasound neuraxial. And we do basically one day there's a didactic, and then we pick 2 other days during the week where we do scanning workshops, where it's literally just, all right, we all get together in the rooms, we grab a bunch of ultrasounds, and then we go ahead and we scan each other. And what's nice about that is that gives you the opportunity to practice those sorts of skills before doing it on a patient. Because a lot of these techniques are done in awake patients. A lot of the regional techniques are done in awake patients. And if you don't look like you know what you're doing, it makes it very uncomfortable for everybody else. So we want to give you guys lots of opportunities to practice these actual skills and techniques before you go ahead and do it on patients. Then that usually ends, I want to say, mid to end November, because then we're already in ITE season. We have a whole ITE series of lectures that hit all the topics. So basically what happens is when we get the results from the year before, we take a look at the areas where we need to have the most support. And we focus our didactics on those specific topics. And that's like a yearly kind of thing that goes. When that happens, we then do another set of practical type lectures, again, with ultrasound workshops and technical skills that we like to focus on. And then after that is the prep for the basic exam. And then once the basic exam finishes, if you can believe it or not, we're already back to the beginning of the year. So that's like the basic cycle of the didactics. Now, interspersed with that are other educational activities. We've really tried really hard to integrate a lot of simulation into our curriculum now. Dr. Hires, he has been so instrumental in really like bringing this to life. It was always a big thing of our residents that they wanted more sim, but he's done a really great job of organizing a lot of those sessions such that now most of our subspecialties, if not all of our subspecialties, have specific simulator curriculums for the residents on those rotations. We do it in peds, we do it in ortho, we do it in OB, we do it in cardiac. So all those areas, you'll get extra time in the simulator. In addition to that, we have our whole POCUS rotation as well. That is sort of like a guided rotation on teaching you guys surface ultrasound, which again, every few years is becoming a bigger part of, what you need to know just to pass your boards. Never mind the fact of being a clinical anesthesiologist, but just passing your boards. When I started, it was like, oh, maybe we'll do this POCUS thing on the OSCE. Then the OSCE came and it was like, oh, okay, can you tell me where the radial artery is? And then it graduated to, oh, can you tell me where the heart is? And the latest, things that are coming out of the ABA is that they're going to start to include things like abdominal and pelvic ultrasound. So there's a whole lot of new material that needs to be incorporated. And as it comes out, that's basically a rotation where you're going to be learning all that stuff. And it's a lot of practical hands-on scanning time because we want to get you guys as comfortable with the scanners as we can. We've invested a lot of time, money, and effort on really amazing novel educational tools. For example, our department purchased on 2 of our ultrasounds this new AI learning technology that basically gives you real-time feedback on your post-POCUS exams. So if you are, trying to do a TTE and you are struggling getting a short axis view, you engage the AI, you put the probe on the patient's chest, and the thing will tell you, oh, rotate the probe this way, rock the probe that way, turn the probe that way, and it will scan the image that you're getting, and it'll give you sort of like a percentage correct kind of like thing to give you that guidance on how to get a good exam. And it does that for all the cardiac views. And we're actually working with the development team to trial some of their newer modules. So really, really cutting edge stuff. We do a lot of education in the virtual and augmented reality space. This last class are the first people to ever use this new virtual reality module that was aimed at teaching emergency front of neck airway access. So actually training to do like a needle crike or a slash trach in virtual reality. Which again is something that's really cool. Dr. Burnett, who I don't know if you're going to meet him today, but you'll definitely hear his name. He is developing a new ultrasound simulator, again, in the virtual space for doing interscaling blocks and upper limb blocks. So you have access to that kind of technology here as well. So in addition to that, we also have an amazing educational platform that's meant to be adaptive. And here, I'll show you. You guys can probably still see my screen now. You can access a lot of this stuff through here. This is the widget that's available in our ORs. You can see some of the makeup of it, but the actual site itself is pretty amazing. It's organized through this engine called C8, but everything that's in this instance was designed, developed, and curated by our own internal people. So these are the internal experts that have decided these are the items that we want to have on here and how it's going to, roll out. In terms of the kind of information that's on here, everything from journal articles, old exams, mock oral boards, textbooks, videos, and it's not just stuff that is meant to be globbed on. It's meant to be like an individual sort of like at your fingertips learning, right? So like, let's say, for example, you are going to be doing like a jet ventilator case, right? And so like, it's like, oh man, I don't know how to set up my jet ventilator, right? Well, here you go. There's a quick setup guide here, right? You search for jet, even set up before that, right? And here's like a YouTube video that we made that, is Eric Franz, also an amazing airway expert. And he's just going to go through and, right? And again, it's a minute long. Right. So we've done this for a lot of our critical pieces of equipment. So that way you guys never feel like you're out of bounds and you can sort of figure out, what you want to do. And then we've got some other really cool tools too. The developer of this platform is someone I've been working with a lot. And we just literally launched this new Ask Panda AI thing. And I've been training it a little bit to do some cool stuff. So you can ask it all sorts of questions like here. I have a case and my patient is on an ACE. Should they stop it, or should they have stopped it? Now, again, it's not perfect. I haven't searched for all these questions, but I throw things at it just to see, and I use that to tailor the content that's on here, and it'll think for a little bit. Again, it says right there, it's in beta. It's in beta. We'll see what it comes up with. Okay. So again, so it'll tell you, oh, that's Tylenol. It said ACE. It said it was acetaminophen, ACE inhibitor. Again, not perfect, but you'll grow with it to some degree. Okay, so there you go. So it automatically found the ACC/AHA guidelines on whether or not to stop ACE inhibitors, and if it has an answer, it will tell you And if not, it will tell you where to find it. And the sources there, you can go and you can click on it. And you can see that Taylor White is our DAS. So he does a lot of our perioperative sort of stuff in our pre-op clinic. So he vets all of that content, on his own. And then you can just click on it and it will bring it up, which is also really, really nice. All the stuff, if you want to go the old fashioned way and sort of, search for it on your own, you can. All of the rotations are in here with goals and objectives. We've set up every single rotation here to have its own sort of guide. So there's all sorts of emails that you'll get and content that you're supposed to digest before coming on rotations. So that way the expectations for each one is met sort of like wholeheartedly. I send out, oral board exams every week to practice that you guys will practice intraoperatively as well with your attendings, who are going to be teaching to you, while you're in the operating room as another way of doing it. And I think, do I have one more? I'm going to take one more minute, right? Did I have 15 minutes? Did I use my 15 minutes?
Just about, but we're fine. It's okay. You can have one more minute.
Okay. Okay, so the final thing that I'm going to say is, of the amazing things that we have to offer you, I didn't think of these myself. Many of these were ideas that other people and oftentimes our residents and our students brought to me and said, hey, this is a good idea. Can we do it? One of the things that I've loved the most about being a part of this department is the degree of innovation and enthusiasm that we have from just trying new stuff. So, if you have an idea when you come here or not, or whatever it is, if you have an idea of something that's really cool that you want to try, let us know. And it's something that we can usually integrate into our educational program. This is something where it changes, from day to day, from hour to hour. So we can iterate really, really fast. And I think that's also another really big strength. All right. So I went 1 minute over time. I'm getting more and more like Adam every day. And I'll stop here if there are any questions. Otherwise, I'll move on. What's coming next? Is it lunch that's next, or what's next?
No, it's the APD talk. So
Okay,
we are all
I'm
here.
still stealing time from you guys. All right. Again, any questions that come up, you can shoot me an email. I'll see you guys out on the interview trail, and good luck to you all.
Thank you, Dan.
Thanks, Dan. Letting me look good.
Even Adam was on time. That's rare. Dan's really trying to follow in your footsteps here. All right, so Ben and Erica, I think, are you guys on as well already?
Yeah, I'm here.
Yep.
Awesome. All right, let me screen share. Welcome. So we're going to talk to you today about just more of the logistics of the program. Adam went through a lot of things in 45 minutes, but we kind of broke down a lot of it. Just go through a lot of just the different parts of the program, the training, the different places you'll go, and all the different opportunities that are available. I think also seeing it sometimes in slides might make it easier for you to digest. Just to introduce ourselves, we'll talk more about ourselves on interview day, but Ben, Eric, and I are 3 of the 4 APDs. Angela, as Adam mentioned earlier, is on maternity leave. We'll be back in about January. So hopefully you guys, if you're interviewing later on, we'll get to meet her during that time. So we'll jump right in. So just to start, who do we seek to train here? What most people find amazing about this program is it's really, like Adam mentioned, a choose your own adventure. And it's really about you choosing the kind of anesthesiologist you want to become. This is not the kind of place where we're trying to force you to become an academic anesthesiologist and you need to be into research. We want whatever you're interested in bringing to the table, whatever you want to do with your career, we want you to explore that and we will make that happen. And so whatever kind of thing you're thinking of, whether it's in education, research, leadership management, administrative work, whether you just want to become, not even just, but become an amazing clinical, just clinician, and when you're going to go into the private practice world, you're going to leave here ready to be that and more. And so what you'll see is throughout this talk, just the various different areas that you can get involved with that'll help you become that kind of person. And if you have ideas that we haven't even thought of yet, that happens too. So we'll jump right in. To start, we're going to go over kind of the different characteristics of where you'll train to. I'll leave Erica if you want to start there.
Sure. Yeah. So there's a few different main training sites that you'll visit, but I think it's worth mentioning that the majority of your time, even during intern year, is still going to be spent at the main hospital on the Upper East Side. So that's the blue little home icon. And other than the main hospital, a few other sites that you may visit. So during your intern year, and after that, for your anesthesia trauma rotation, you're going to go to Elmhurst. During your intern year, you may be there for your ICU experience, for your surgery experience. And then once your CA 1 through 3, you'll be there to get your trauma experience. And they're doing, honestly, a lot more pediatrics and regional and even some pain, a lot more than they were a few years ago. So you're really not just getting trauma when you go to Elmhurst, and you're working with a lot of the attendings there are Sinai graduates as well, which is cool. Up in the VA, so up in the Bronx, you're going to go to the VA here and there, and that's what Mark's circling now, the green icon. And the VA is a really unique place. If you aren't, if you aren't familiar, the VA is sort of a greater network of hospitals, and so we are affiliated with the VA in the Bronx, which is just one of the VAs in New York City. Again, something that's kind of cool there. A lot of the attendings there are also graduates of our residency program, so you kind of get to work with some, some people that trained in a familiar way, but have been working in a very different setting for a while. And the patient population is obviously very particular there, so they're all veterans. And the sort of the way the anesthesia department and the whole hospital works is very different there. So it's really unique and it's fun to work there. The attendings have a lot of fun there, and the residents usually have a lot of fun there. And the pain rotation that you do there, there's either, during your CA3 year, you do an anesthesia rotation there, or you can also choose to do a pain elective. And they do, I don't know if they do more, but they do quite a lot of fluoro guided procedures, a lot of hands-on procedures. So you will find yourself in lead doing hands-on pain procedures, which is pretty cool and unique. And inevitably, some of our graduates end up wanting to work there because they kind of get a sort of a feel for the way the environment and the anesthesia department operates there. And it's definitely a little bit different than our anesthesia environment at the main hospital. Over on the west side, Mount Sinai West, so that's that little red W, that's going to be, so as you already probably know, that's its own anesthesiology residency program, but we do send our residents there if they'd like to go during their CA3 year to get more regional experience, more experience with blocks. There are plenty of blocks at the main hospital, but I think for those residents that are really motivated to, feel even more comfortable with maybe more block experience than they've gotten at Sinai and just want to spend more time doing regional or again, working in a different environment, then you can spend 2 weeks out of a month, and you can do that a few times. So you could do that block more than once during your CA3 year and go and do more regional there and work with some of the folks over at West. Again, some of who are also graduates of this program, but many are graduates of the program on the west side as well. And then the private office-based anesthesia rotation is sort of a cluster of a few different private plastic surgeon offices, but that gray P is sort of where some of them are located. So locations like Park Avenue, usually in the 70s or 80s, so very, very she fancy area of the city. These are not at all like the operating rooms you're used to seeing. These are private plastic surgeons' offices with sort of surgical or operating suites in there. They are only taking care of very healthy patients. You're not going to encounter any of the sick patients that you're used to seeing when you're at the main hospital. But these are patients that pay out of pocket to have a certain type of experience. It's discreet. They want it to be, as pleasant as possible. And so that is something that if you're interested in seeing a little bit of, you can do as a CA3 and spend some time with. There's a sort of a handful of consistent faculty that tend to work at those sites from our department. So they can kind of show you the ropes and give you a taste of what that type of anesthesia looks like. And you may decide you never want to do that again or that you really like it. But it's definitely unique. And I did that rotation and I liked it a lot. And I think it's too early to say for sure, but in general, the trend is that we've been opening up a lot more ambulatory centers, I would say. So those for endoscopy, those for plastic surgery, and then for sure, more recently, our ortho ambulatory center has opened up. So maybe, if the volume really picks up and we have enough, we'll be able to send some CA3s there as well to really feel what it's like doing ortho in an ASC where efficiency is paramount, and maybe you have a little bit of a different structure for blocks than we do at the main hospital. So you really get a variety, but you're not going to be all over the city on any given day, not knowing where you're going. The Upper East Side is still going to be your home. So I think that's something that's really unique and nice about the program also.
Yeah, our AmSurg Center, we don't have it listed on here, but we just opened this up. It's all orthopedic procedures that our residents, since it only just opened up like the last week or two, it's still kind of getting moving, but our residents should hopefully be joining by, I'd say, the end of this academic year. And certainly by the time you guys are residents, you'll be able to go there as well. So, the amount of non-OR anesthesia, just anesthetics, is over 50-60% of all anesthetics being done in the country. So it really is important to be able to get your feet wet at those office-based anesthesia areas and AmSurg centers, ASCs. So just to break down each of those hospitals, the Mount Sinai Hospital over on, it's about 101st between Madison and Fifth Avenue, is where you do everything. In terms of every ACGME requirement, all of it gets done here. The only 2 months that we have you go somewhere else are 2 months at Elmhurst, where you can get trauma, but again, that's not even a required ACGME experience. And as Erica mentioned, they're now doing so many more peds and regional experiences that you get to do a lot there. But all the other things we've mentioned before are all electives. So what a lot of people like is that you're going to be here at the main hospital all the time doing every procedure that you need to do. We have almost 1,300 beds at this point now at our facility, over 100,000 anesthetics per year. We do about 250 cases per day, 10,000 deliveries per year, and a lot of blocks, a lot of cardiothoracic. As you can see, the numbers of different procedures we do are extensive. Our neurointerventional procedures have gone up substantially down in what we call the basement, down in interventional radiology. And as Adam mentioned earlier, because we've kind of conglomerated our Mount Sinai health system and taken different sites and taken them in, pediatric cases have blown up. So when I was a resident 10 years ago, we didn't do as much peds at all. And now we have anywhere from about 5 to 7 peds ORs running, from GU, orthopedics, to endoscopies, to interventional neuro, to general neuro cases, to what else? Just general peds cases. It's quite extensive. So the residents themselves get a lot of peds experience. And I've actually found that I think more of our residents are going into peds fellowship now in the last few years, just given that experience and how much they're loving it. And transplants, Erica will probably tell you in a bit. So I know as a transplant anesthesiologist, she does a lot of livers per year, but just on top of just livers, the amount of kidneys and small bowels, pancreas, we even did the first tracheal transplant in the country here. And so we do a lot of transplants, which also the residents love to do. And what's great about our location is, yes, we're on the Upper East Side, but you're really on the border of the Upper East Side and Spanish Harlem. And it's just very unique to have a zip code where on a given day, you're going to have patients who, may consider themselves VIPs. They may be a celebrity, maybe someone that owns like a Fortune 500 company, but also you're going to have the next patient be someone who we have the projects right across the street from us and have just come across the street and are, very underserved. And so you get to take care of everyone all at once. And so it's not the kind of hospital where all your patients are just one kind of Upper East Side, fancy person that you're not going to get a hands-on experience. We treat everyone the same. And I think that's what's so unique about being here is that you, in one day, will take care of people from all different walks of life, but they're all treated the same. And so I think that's what makes this place special, that you have that. On top of the fact that you're located right across from Central Park, you'll see that everyone's eating outside all the time, just sitting right by the park and enjoying that. So it's a great place to train and just a great place to be. I myself have lived on this, within a 10-minute walk of the hospital for the last 10 years. And I think it's a great place to raise a family even. It's great.
So I think Elmhurst deserves a little more face time. So as we've alluded to, Elmhurst is one of the affiliates. It's a really unique location and hospital in New York City. So it's a level 1 trauma center. And I went to med school at Downstate. And so I was used to Kings County, which was our huge level 1 trauma center in Brooklyn. And I found like this felt very similar when I got there in terms of a few things. And then it definitely had some differences. So overall, the population served by Elmhurst Hospital is extremely diverse. I think it may be one of the most ethnically diverse communities in the world. And on top of that, it's right near, or basically kind of sandwiched between / right near the 2 major airports in New York City. So LaGuardia, JFK, and surrounded by one of the most ethnically diverse communities. So you really have no idea what type of patient population, language, what type of medical literacy is going to walk through the door at any time. And to add to that, it's a level 1 trauma center in the middle of New York City, so it's incredibly busy, and there's all different kinds of mechanism of trauma. So it's a city hospital, as it says down there. There's no private patients, so you obviously do have all types of people walking through the door, but you very commonly have people that have very little medical literacy. They're very trusting, or they may not be very trusting in the medical system, depending on their experiences. And they could speak one of 1,000 different languages. So it's really a unique experience. And it's part of overall it's called the, NYC Health and Hospital Corporation. So that also includes Kings County and Bellevue, other hospitals you may have heard of that some of the other programs are associated with. And so, it's kind of great because you get that really raw city trauma experience, but you do also get a ton of support. You're going to recognize all the residents you're with. Of course, they're going to be your co-residents. And then a lot of the anesthesia attendings there are graduates of our program. So you're going to be very well supported, but you are going to have more, I would say more or different autonomy than you even have at the main hospital. You're going to be, responding to a lot of airways. There is not really a rapid response team at Elmhurst the way there is at Sinai. So you are the front line in terms of airways, in terms of codes on the floor, which is really great and important. And I think that as RRT has taken some of the volume at the main hospital, we really, really rely on those Elmhurst airways. And so you really grow up there, but with support. And I think, a lot of the residents really love the experience there. They choose to do more than the required rotations and end up going to Elmhurst a few different times. There's CA3 year. The food is really nice there. There's all different kinds of food there, and it's really inexpensive. And so you can probably do all kinds of different food crawls during the 1 month that you're there. And there's a shuttle there. So I think if we haven't already mentioned that, it's worth saying that if you're on a rotation and you're going all the way to Queens, which isn't, right next door to Sinai, there's a shuttle. So obviously it's up to you if you choose to take it. If you live somewhere or, your timing is such that you think it's more convenient to take the subway, there are definitely subways that take you just a few blocks, but there's going to be shuttles. So you can just show up at the hospital, hop on the shuttle with your other co-residents and residents from other programs, Sinai, and close your eyes and buy yourself 20 more minutes of sleep, and they'll drop you off right at the door. So of course, also in terms of off hours or feeling safe, if you are traveling to and from and it's past the hours of the shuttle, there is a Sinai reimbursed Uber. So there is never a situation where you should be taking a subway back from Queens feeling uncomfortable or anything like that. So really by being able to go there, it's like all benefit and no downside. And it's really, really a unique I know I said it about the VA, but it's true. All of these sites are different and unique, and they're not like each other. And so it helps you, get a sense of where you may want to work once you're finished with residency too, because these places all operate very differently and the patients receive you differently. And I think I said this before, but they're doing, they've always done some pediatrics. Barbara Delos is in charge there, and she's a pediatric anesthesiologist, but also now with some more of our recent graduates, they're doing a lot more blocks than they used to. There's always been neurosurgery there, and a lot of the ENT colleagues that we operate and work with, at the main hospital work together with us there too. So it's a really great experience. And if you don't want to do more than, the few months that you have to do, you don't have to, but most people choose to because it's just such a great rotation.
Yeah, since Barbara took over, I think it was 2018 maybe, or 19, she, has basically taken at least one or two of our graduates per year. People love working there, and it really has become like a second Sinai of sort. And you can't also beat that food. I've heard now that they actually cater in lunch from places around the area every day. I don't think that was the case when I was a resident, but Monday through Friday, lunch is catered, and then obviously your attending will order in dinner for you when you're on call there from any of the other places too.
It's a nice neighborhood. Like they support the neighborhood, and the neighborhood kind of supports them. So it's really nice. They should be ordering every day.
Mm-hmm. And so those are the two, between Mount Sinai Hospital and Elmhurst, those are the only two sites that you're required to go to while you're here during those 4 years. Everything else are electives that you can choose to go to or not go to, depending on what kind of training you want. As a CA3, we have two electives that happen at the VA. One, which is in general, and another, which is in pain. A lot of the residents love the pain rotation there because there are no fellows, and it's just you and an attending and do all the procedures there. So it really is well coveted by anyone going into pain or just anyone who wants to just get more hands-on experience doing pain procedures. On top of that, they also do some very large cases, thoracic, major vascular, that in the general anesthesia world are great cases to get to explore as well, just to see a different site. As a CA3, it's really nice when you're going to feel very confident as a CA3 that you can do pretty much anything. But it's good to also then just go somewhere that you haven't been to, just to see how it's like at another institution, because eventually you might go somewhere else too and feel that way as well. The other two electives that we do, as a CA3, you can go to West and do a little bit more regional there. It is the New York School of Regional Anesthesia, so there's plenty of different blocks that get to have every day. On top of that, I also mentioned that office-based anesthesia, you get to go to the plastics world of Park Avenue, the high-end private payers that you see in the Upper East Side. So it's very unique because those are not places that training sites go to, but they allow our attendings who are there rotating through there, they'll allow them to bring the resident and get to be part of it. And so as a CA3, you can do that for the month. And as you'll see, by the time you're a resident here, that office-based anesthesia practice, we're really going to turn it more into a non-OR anesthesia or non-hospital anesthesia. And so you'll also be going to like our ASC and just get to see different sites that you can do outside the hospital as an anesthesiologist.
So this slide just kind of goes over the overall progression throughout your 4 years of residency at Mount Sinai. So your clinical-based year is your internship. And actually, as Adam was saying before, this year has really changed pretty dramatically over the past couple of years. When I was an intern at Sinai, like for example, we didn't have POCUS, we didn't have PACU or pre-op clinic, and so now we have all these additional rotations for you guys, which is great because the POCUS, PACU and pre-op clinic, pain and anesthesiology rotations are all part of our department. So essentially 25% of your internship is going to be with us, which we're super excited about. The other nice thing about the internship year is that you will make probably lifelong friends with the other members of, the medicine residencies and surgery residencies. And I think this is a really great thing, especially when you start CA1 year, because you'll know a lot of the surgery residents when you start working in the ORs, and it just helps so much when you know people. You're able to work better together, and it's just a better environment. So I think that's a huge plus to our categorical program. So essentially intern year, you'll do medicine, surgery, crit care. The CCU is a great rotation where you learn all about the critically care cardiac patients. ENT is also a great rotation where you'll see a lot of difficult airways, and then all of those 4 blocks within our department. And then CA1 year, July 1st, you'll start your intro to anesthesiology. We'll call that the boot camp. So essentially the way that works is you're assigned to an intending to work with exclusively for pretty much 2 months. You start off, you're never left alone for about 2 weeks, and you're just one-on-one with that attending. And then as time goes on, you're slowly left more and more alone, and then you're eventually double covered. And then by September, you've essentially graduated from boot camp. During that time as well, we have a high fidelity simulation curriculum for you where you'll have a lecture typically on Mondays, and then you'll have 2 high fidelity simulations during the week. These are really, really great simulations. I certainly still remember them from when I was a CA1, and now I help teach them. But they really help reinforce all the basic concepts that you guys need to know. And then pretty much starting in block 4, you'll start, exploring some specialty rotations. So like OB, for example, where you learn how to do spinals and epidurals and learn how to manage the labor floor. That's always a great first month for residents. There's peds, ortho, trauma, where you'll go to Elmhurst that we were just talking about. The nice thing about the trauma rotation is that it is at a different hospital at Elmhurst. So everything's different there. The IV tubing sets are different, the laryngoscopes are different. And so the machines are different, anesthesia machines. So it's just it's a way to see how things are done at another place. In addition to getting that very high risk trauma patients. We do very high risk neuro here, where we do craniotomies and multi-level spinal surgeries. And then neuro, which is the non-OR anesthesia, which is mostly interventional radiology and endoscopy and cystoscopy. And you'll see we take care of extremely sick patients in those locations, which is very educational for our residents. Once you get into CA2 year, so CA2 year, you'll probably want to decide if you're going to not do a fellowship or do a fellowship. And so for those of you who are considering a fellowship, you would let us know and essentially let us know what you're considering. We try to give you those rotations early. So you'll do cardiac and you'll do more subspecialty rotations that year. So cardiac, airway, liver transplant. As we were saying, we do tons of liver transplants here where you learn to put in very big IVs, RIC lines, central lines, Swan catheters. It's a really excellent rotation and you learn a lot. You'll do the CT-ICU and a month of pain and regional, and then essentially some other subspecialties. Really, whatever you're interested in. If you're thinking about fellowship, we'll try to get you those rotations early. And then CA3 year is essentially, it's your year to do whatever you want with. So there's a couple required rotations. That's when you'll do your thoracic rotation and PACU rotation. And then pretty much the rest of the year is elective time. So it's time to, repeat blocks, to get an additional experience in certain subspecialties and really to do whatever you want with the year.
So as Ben mentioned, the CA0 year or intern year, it's quite impressive now that we have 30 interns. We've really changed it up, and it's actually close to 40% of your year. You're on what we call green block, where you're on ENT, pain, anesthesia, POCUS, pre-op clinic, PACU. During that whole time, that 40% of your year, there's no call, there's no weekends. So it's quite nice as an intern now. You do what's it called? You do 2.5 months of surgery and then 1 month of surgery ICU and 2 months of medicine and a month of CCU. So it's a pretty great experience, and you get to also really, what you'll have is you'll always have someone else with you from your rotation on anesthesia. So as you see here, as you kind of go through it, there's like 2 people on ED, 2 people on ENT, anesthesia. You usually call them like your work spouse. And that person really helps you kind of go through the year to know that, yes, you're going to become very friendly with the medicine people, the surgery people. I remember, I mean, those co-interns I had on surgery and medicine, I went to their weddings like when they found someone years later because we were still so friendly. And certainly in surgery, you're going to work with those people every day for the next 3 years after intern year, that you really do get close, and you'll be texting them like, hey, this patient for tomorrow, like I see they're on your team, like can you make sure they're optimized? On top of that, the person you work with every day as your work spouse, they definitely come close with you. I know even like Erica, she just got married a few weeks ago, and her work spouse, Carlos, he was there at the wedding as well. Not her, it was not actually her spouse, but
Yeah, I was going to say, no, but he's now engaged to his new spouse. And we've traveled like literally all over the world together. And I was in Africa with his parents and was at his sister's wedding in Colombia. So it's really, really nice. And I don't think we would have gotten so close if it wasn't for spending all that time together intern year.
yeah, intern year, look, it is tough when you're on those other services, you're doing surgery, you're doing medicine, you really become part of those services. They treat you like their own, whether that's good or bad. But we're always there to protect you. We're always there for you. And so that's what's great about this, is that you become really part of those services. But at the end of the day, you know that your home base is always here. We have a floor of our department, KCC 804. It's the building that if you come visit, all of our offices are here. And we have bagels every day. And we always see interns from every rotation coming by, saying hello. And knowing that if there was anything ever wrong, they would come to us to make sure that everything's okay. So you're well taken care of even as an intern. They may feel like you're sometimes part of another service. You're always part of us as well. Erica, do you want to talk about the didactic saw?
Sure. So this is a sample didactic schedule, and didactics tend to be at 6:30 in the morning. So typically the workflow is that, depending on what time your OR starts, the residents usually come in prior to the 6:30 lecture start time, get some setup done in their room, and then come to lecture, which is usually about 6:30 to 7, which gives them plenty of time to, finish any setup afterwards or go see their patient before their start time. And we actually recently had the pharmacies start opening up a little bit earlier so that there's less bottlenecking and less crowding when everybody's trying to get their drugs in the morning. And so there's a whole team of people, but so obviously we have our teaching chiefs, and then we have a few faculty in charge of education. So Ben previously was one of those people, and now Patrick Mafucci is doing that job. Dan Katz has a huge role as well. And so I think they're always really receptive to feedback and tweaking this as we go. But just like we said, this is a sample. So at 6:30, you could see on Monday that they're on the 31st there. So it's like a financial talk. And so I think, sometimes we have a handful of faculty that sort of are really good at breaking down some of the finances and some of the things that you should know as you're finishing up residency to sort of save smartly and plan for retirement. And so that's an example of a talk there. Usually once a week, we have Adam rounds, which are very, very unique. Typically a bunch of, this is all mostly very informal. So it's in one of our large conference rooms. We just sort of sit around the table, and Adam usually asks somebody to bring forward a case from the, prior week that might've been really challenging or something unique. and sort of break it down step by step, super interactive. And usually at some point during the Adam rounds, you end up talking about some topic and you have no idea how you got there, but usually you learn a lot, whether you get to the end of the actual case you started with or not. And so on Wednesdays, every Wednesday we have departmental conference. So usually at 6:30, there is a lecture for the residents that pertains to the topic that's going to be discussed at Grand Rounds. And then at 7 is the entire department. So it's attendings and residents. We're fortunate enough that we're in person again and have been for a while. And as with every morning, there are free bagels and coffee, if that wasn't mentioned. So you are going to be coming in at 6:30 for your lectures, but there are free bagels and coffee every single morning from Essa Bagels. So if you don't know, now you know. It's a really, really well-known New York bagel spot that a lot of people would wait online and pay for their bagels over and over again, but you get them for free every morning. So Grand Rounds on Wednesday, sometimes it's M&M, which is usually a presentation by one of the teaching chiefs or one of the administrative chiefs going over a case. And then sometimes we'll have guest lecturers and then each CA3 does, or sometimes at the end of CA2 year, takes their turn at a presentation. And so they all take a turn in at any given morning. It may be one of the CA3s presenting a case with one of the attendings moderating. And Dave Rich also will do journal club. So not on Wednesdays, but usually I think it's changed. It used to be on Thursdays. And so Dave Rich, if you don't know, he used to be the chair of the department and then the president of the hospital. And he still takes time out of his week and he does journal club with the department, or sorry, just the residents actually. So it's a really small interactive setting where you get this FaceTime with someone who's, held such a huge role in our department, holds such a huge role in the hospital. And he really spends time breaking down articles with you and going over a lot of the basics. And I remember for me, he helped make a lot of the sort of journals and approaching them a lot less scary than I had thought they were. And so he's a really great guy, and it's really unique and nice to be able to spend that time with him in such a small room. And then you can just see sometimes, depending on the subspecialty rotation that you're on, the subspecialties will divide up how they teach things differently. Sometimes because OB has a certain distinct schedule, they're able to carve out some dedicated time in the morning. Sometimes, I know, speaking from a liver transplant perspective, if the liver transplant aspect makes things a little unpredictable, we spend a lot of time teaching in the operating room as well. And we do have our fellows help us sometimes get the residents out for simulations and things like that. I'm sure I'm missing things, Ben, so feel free to plug any gaps I left.
No, I think that was great. Yeah.
Jumping right into then each year, we'll go through the CA1, 2, and 3 year, and just kind of, these are schedules of our residents and what they've done. What you'll see is that those, Ben I mentioned before, those first 3 months of your CA1 year, we just assign you to just general anesthesia, and you're paired with a preceptor. And so this person becomes your mentor for at least for 2 months, that one-on-one, they'll really see how you're progressing. It's a way to kind of make sure that every different day you're not going to someone and they don't really know who you are, not trusting you. You build that bond to see your growth and make sure you're doing okay until you're ready to start being left alone a little bit, until you start ready to be, double covered, then all of a sudden by someone else. And so it's a nice progression that you have a lot of oversight during that time until you're ready to really start spreading your wings and fly. Also, as I mentioned during that time, you're going to have lectures every day that are all based on like the basic anesthesia principles. They'll go through certain week topics. So there'll be an induction week, an emergence week, a hypoxia week, hypotension. We go through each of these topics each month, also pairing with, with simulations as well. So the actual curriculum is great while you're in it. That then leads you to eventually go through all the different subspecialties. And during CA1 year, you're going to get exposed to everything. So once you are done doing your basics of anesthesia over the first 3 months, you're going to start doing every subspecialty from neuro, orthopedics, peds, OB, cardiac, ENT, SICU, the non-OR anesthesia. In this time, you get to see a little bit of everything, and it's certainly our introduction to each of those, so that CA2 year, you'll get to explore them again. But it really gives you the kind of necessary, just basic building blocks to say, okay, do I want to do a fellowship? Am I interested in this? Like, let me re-explore for next year. Because CA2 year, as crazy as it is, you have to start thinking about fellowship. And so our CA2s, they start applying to fellowship very soon. And it's already, only October, November of the year. And so what we do is in April, so all the APDs, we send out an email and basically saying, okay, what are you interested in doing as a fellow? Do you want to do any of these as top 1 through 3 or 4 different choices? And what we make sure is when we make the schedule, that we will actually have it in an order that makes sense, that you will get to do, if you want to do liver, do a little early, so that this way you can explore it and make sure that that's the right thing for you. So you'll see here, you have Marc Gasol, maybe interested in liver. He got to do it by October, and crazy enough, he chose to do liver. We have, let's see who else. We have Salvo and wanting to do peds pretty early on. Guess what? He did peds. We have a few people doing cardiac. We have, we'll go through all the different fellows for next year, but it really is something that you get to explore early. And so this way, by the time you have to get your letters of rec, get all your apps in, you've done all the subspecialties early on. And so the CA2 year is interesting because there is the kind of choose your own adventure in that you're going to get to pick the order of things. But for the most part, the 13 blocks you go through are pretty much set in stone in which rotations they are. And it's essentially just the part 2 of those subspecialties you explored before. So you're going to do cardiac again. You're going to do CT-ICU. You're going to do peds 2, OB 2, neuro 2, regional. So it's kind of more of a higher level of those cases that you had before, but certainly the sicker patients, the more complex cases that you're doing throughout that. Erica, do you want to talk about CA3 year?
Sure. So CA3 year is really great because it's almost entirely up to you how you structure it and what you structure it with. So there are a few things that you're definitely going to do. So you're going to have your TEE/TTE/POCUS/PACU rotation. So 2 of those weeks are going to be spent covering the PACU. And now coming in, as an intern, you will have had a taste of PACU as an intern, and then you're going to come full circle and really take that role on as a CA3, and where you're going to really be calling the shots, managing the PACU together with the attendings covering PACU for that day. And it's nice to have that in a sort of contiguous 2-week block because you get the swing of things. For better or for worse, you may have the same patient in the PACU for 2 days in a row because they've gone to the OR back and forth, or because they've been sleeping there because there's no beds upstairs. So there is some continuity. We also, PACU has changed so much since all 3 of us were residents, but we have a really excellent team of PAs now that help in the PACU, so that occasionally when you're on your, usually at least once a day when you're on your PACU rotation, there are these ambulatory sedation pediatric procedures that happen in one of our procedure rooms there. And so you may be covering or doing the anesthesia for a relatively quick bone marrow biopsy for a pediatric patient. And while you've been in that procedure, a few patients have come out of the operating rooms. And so when you get out of that procedure, the PAs can fill you in on which slots are new and what they've had done. Whereas if you can imagine, years ago, you used to just have to figure that out for yourself when you got out of the procedure, and things were, a little more chaotic. But we also are so much busier now, and the PACU is so often like an ICU that it's really wasn't able to continue to function that way. So you will feel a little bit of your ICU rotations in that PACU rotation, and then you'll also get to see, how different patients come out from different anesthetics, what you like, what you don't, what things you might not have realized happen 15 minutes after you leave your patient in the PACU, and what you might want to do differently to avoid that. So I really loved it. I would have done more if I could have. I think it's really great that we now get to do that as an intern. And certainly when time allows it, you will, during your PACU 2 weeks, you'll go to any POCUS lectures, and the PAs are able to help cover you for that. And you can also use the patients when appropriate and when they're willing to, allow you to practice things like TE, probably not TEE. But you will definitely have some patients hanging out. Maybe, they're not in pain, and they're more than happy to learn with you and the team as you kind of go over their TTE exam. And then we've actually had some motivated residents who wanted to get TEE certifications, who, when they had free time on their PACU rotation, would pop into a liver transplant operating room or the cardiac cluster and log some TEE exams and findings, and were able to, I think Jake Rubin last year was able to get his 50 numbers to get certified for that. So there's, you can sort of make as much or as little as you want out of it, but even at the least, it's going to be a really nice 2 weeks of learning. And POCUS is excellent as well. So you'll get the same lecture schedule as you did as an intern, but sort of what you get out of it as a CA3 is a little bit different. And maybe you'll even have more of a teaching role. And so those POCUS lectures are on anything from TTE to FAST exam. Mark teaches the FAST exam, and some of my liver colleagues teach some of the TEE and TTE. And then a lot of our regional colleagues teach as well for that curriculum. Something that's a CA3 exclusive role is your team leader role. So when you are on call, there is a new call as a CA3 called team leader. And this is a call that really prepares you to be an attending, prepares you to work potentially in, in a setting as an attending where you may need to coordinate operating rooms. So this is something where your call starts at 4 p.m. and you will take over the PACU at that point. So whichever PACU resident and attending are on, you're going to round at 4 p.m. with you and with the attending on overnight, and you guys will take over coverage of the PACU at that point. The PAs do hang out for a few more hours past that, but at around 7 p.m. they're gone. And so it's just you and the attending manning the PACU overnight. You're also going to help coordinate with the third. So the third call attending is someone who's really running the board, and you're going to help them figure out relief, figure out which residents are most appropriate to take over on certain cases and which maybe require a senior resident, to figure out how to staff any emergencies and how to get residents out for dinner breaks. You're going to at all times be holding that PACU pager, so you may be supervising getting a case started and then have to go attend to something in the PACU. You'll also be helping out with any airways because at the Bain Hospital, our CA1s are not going to airways by themselves. There's just no need. There's a lot of us there. And you're also going to be getting pages and calls from other surgical services trying to book their cases, saying they have an emergency, or the case that's been waiting all day is now an emergency. And maybe you have a few emergencies and they're being called at once. And so you and the attending have to sort of figure out what takes priority and to professionally delegate and explain why one surgeon may be able to go and the other can't. And so it's really not a simple role, and it takes practice. And in the beginning it's a lot, and I think by the end of the year it's kind of cool to see how much you've mastered it and how it isn't as hard as you thought it was to sort of keep an eye on the PACU and be able to start a case with one of the junior residents and help coordinate breaks. And if you can manage all that by the time you're graduating, then you're really in a unique role. And I think that's a big part of why our residents are so prepared once they finish residency, because this is really something that a lot of people don't get to experience until they're an attending. And I think this just goes along with what we say often, which is you shouldn't experience anything for the first time as an attending. So why not get good at it during your CA3 year?
In our last 5 minutes, we're just going to go through a few more things in the program. One other really great part of our program is the autonomy you get with your vacation and wellness days. So we treat you guys like attendings. We expect you to be just like us. If we want to treat you that way, you should also have the same benefits like your vacation calendar. So unlike where a lot of places you may have to take a week or 2 weeks at a time, or even like surgery here does a whole month at a time of all their vacation, your 20 vacation days that you get per the ACGME per year, you get to do whatever you want and how you want to organize them. So you have your own little scheduler. You could pick the days, you go through the calendar and actually assign them whenever you want. And so the residents kind of love that, because you may just take a vacation day, say like on a Friday, and ask for a call day from the Chiefs on a Wednesday, and now all of a sudden you have 4 days off because you had just one vacation day that you used for that. So the residents, while they do work really hard, they also really balance that with just the ability to have the autonomy and independence to like book their own vacation, take care of their own life, their own wellness. Wellness days are days used for doctor's appointments, for taking care of their family members. You get one of those per quarter as well on top of their vacation days. And honestly, if you ever needed anything, the program director, the APDs were all here for you at any time, and people know that they can come to us for whatever they need if they ever needed to move time around, if there was a day that's not available. So just kind of going back to the beginning where we talked about who do we train, we have all these tracks that we're going to briefly mention. You're going to hear about all the tracks very soon. After lunch break, we'll have each of the different track directors come and talk to you. But we, just in the last 4 years, have created multiple new tracks. I mean, when I was a resident, it was just the research track and the educator track. But since that time, we've exploded with new ones. And, as we had mentioned before, the educator track has really solidified itself now with its own separate, just research education track as well. It's really kind of blown up. And so I just wanted to show you, the different things that our Eliasberg residents are doing, from publications to doing the anatomy class that Mafucci had just created that Adam mentioned before. They're very involved in the NYSSA, the New York State Society of Anesthesia, and the ASA. The NYSSA presidents, since, I want to say, Erica, are you the first of like the line of 6 or 7 years of just people running the NYSSA?
Yeah, I think Mira held it, and then it was a few years off, and then it was me in 2020, and every president since then has been from our program.
So you'll hear more about the track soon, so I don't want to take too much of your time away with that. The other thing that I don't think I mentioned before, but since COVID, we used to have a lot more medical missions. It went away when the whole world shut down with COVID, and it took some time for the hospital to get them back going. In the last year, We've now had our Zambia mission, and we have another one coming up in Grenada. Erica was actually there. I don't know if you want to mention anything about it, Erica.
Yeah, I mean, it was, and obviously for anyone who wants to hear more about this, I know we have limited time, so please reach out and I can tell you as much as you want to hear about it. But it was really great. We went for 2 weeks. We were in Lusaka, which is the capital of Zambia, and we worked with one of the university hospitals there, and we're there in a clinical teaching role for the residents. There were a lot of attendings there that didn't have experience with procedures like epidurals and nerve blocks. They just got an ultrasound recently, so we were there to try to teach them a lot of those procedures, and it was really eye-opening. I mean, they were super grateful to have us. It was really fun working with them, but their resources were extremely limited. They canceled cases towards the afternoon on most days because they started to run out of oxygen. They had shortages of local anesthesia. We got to see and use halothane, suxamethonium, and a lot of other things that, you probably, we were putting iperidine in spinals because they had a fentanyl shortage. So it was, and we were really well taken care of. They housed us. We felt very safe. We had transportation. And then the photo on the right, we got to do a safari and go to Victoria Falls on our weekend off. So it was awesome. And if I don't go again, it's only to give somebody else a chance.
Other things to touch upon, working here, what's amazing is that the anesthesiologists are everywhere. Running the hospital, like David Rich, the president and CEO of the hospital, from patient safety to finance, you find us everywhere. And I think because of that, we're such a well-respected department that wherever you work within the hospital, you get treated like a physician. It's not like this thing where you're just somewhere, oh, you're just here to help out the surgeons. I've never felt that in all the years of working here. We really do run this place, and I think having that respect makes it a great place to work because everyone really looks at you in such high regard. Other things that are benefits here, meetings and conferences. So unlike a lot of other places, we actually can give you unlimited resources to go and present as much as you want. So if you have any original work, abstracts, we will send you to every single conference and presentation you want to go to. As on top of that, if you don't have any work, but you just want to go to present or just go to a conference without presenting, we actually will fund you to go to any one conference for your residency that's not a presenter conference, and also one medically challenging case. So our residents love to go to the ASA. We had a lot of people at the ASA this last weekend and throughout the years. And so they definitely go to their conferences throughout the year as well. Fellowships, we have a lot of fellowships. I think, as Adam mentioned, every single one except PEDS is offered here. And often our residents like to go into them. You'll see this past match that we've had for this coming year. We have about 12 or 13, usually anywhere from like 12 to 15, or almost 50% of our residents will go into fellowship. The last year or two, it's been a little bit less because the market is so good that people are just getting jobs. But even still, there's a lot of different fellowships going to the best places around the country. It's wherever you want to go, you'll pretty much get to go because the market's so good right now. And lastly, it's New York City. It's the best place to live in the entire world. So the residents take advantage of that, whether it's going to shows, going to the best food, just hanging out. We do resident versus attending softball games, just different hangouts. We have social chairs. The social chairs are actually the people that you've probably been interacting. If you are going to do any of the in-person happy hours, we have nothing to do with that. We don't even know who's going. But our social chairs plan and organize lots of events throughout the year, including making sure that you guys get to hang out with our residents during the interview season. We do wine tours on Long Island. Erica started that when she was a social chair.
We need new pictures.
Me too. But we have a lot of fun activities here, and you get to hear more about this on your interview day when you get to meet us. Lastly, you can follow us on social media, and you'll see even more of those different activities happening throughout the residency. So I know we were like a minute over or 2 minutes over because I blame Dan because he started us off that way. But we want to make sure you have time to stretch your legs, take a break, have some lunch. At 1:15, we have the beginning here. At 1:15, you'll meet all the different track directors. They'll come talk to you for a little bit each. But also on the interview day, you get to talk to us too, and we can give you all the information about that. We'll talk about wellness and then close out by 2 o'clock. So enjoy a little bit of break time, and we'll see you after lunch.
See, it isn't just me.
You trained us well to be like you. Just know how to keep talking and talking and never stop. It's in our
Exactly.
nature.
Perfect.
Hi, everybody. Mark, Adam, do you want me to get started?
Yeah, that'd be
Uh,
great. We may give it 1 more minute just till like 1:15,
Sure, yeah.
just so everyone's back from lunch. But I think once the clock strikes 1:15, we're good to go.
Okay, cool.
Thank you, Sam.
and and just for the audience members, like I introduced Dan, I'm going to introduce Sam and John, because actually both were also chief residents. Sam was also an educator chief and a administrative chief, as was Dan. John was one of our administrative chiefs. And Sam was actually our first Eliasberg recipient of the research scholarship when he joined our residency in 2007. 2007? Is that true? My goodness.
Yeah, it's
Um,
embarrassing. It's embarrassing, right? Time is flying.
yeah, I'd like to think that you guys are just getting older and I'm just staying, my age. Unfortunately, that's probably not the reality, but in my brain it is.
Yeah.
Um, and can't be more proud of his career trajectory. It's kind of extraordinary. Sam also, just like Dan, just like John, their career trajectories were just really set on a pathway of success. From their residency, they were enthusiastically involved in doing things beyond what was expected of them as residents. And both of them became full professors within a decade of finishing their residencies and have taken on major leadership roles, not only departmentally, but institutionally and nationally. And we have the pleasure and the blessing to have them, to have all of these role models stay on. And what was envisioned then has actually come to fruition is that if you develop one's career as residents and then they stay on and they go from mentee to mentor, and that's precisely my story. I went from being a mentee to being a mentor, and it's really the trajectory that sort of has been created here at Sinai, and it continues to be fostered. So, without further ado, I don't want to step on any toes because what they have to say is important stuff and makes our program exceedingly novel and unique. And I'll turn it over to Sam, and then I think John, and I can talk about the education, the DEI and innovation and the education scholarship as well. Cool. Thanks, Sam.
Yep, no problem. Thanks, Adam, for a very nice introduction. I appreciate it. I'm Sam. As Adam mentioned, I've been here for a while now. It feels like yesterday, honestly, which is kind of crazy to think that I've been faculty here for 15 years. So that's kind of a weird thing for me. I feel older every day when I realize that, like, I learn more about what the residents are into from like what my son is into. And so that's always disheartening. But I forge ahead as best as I can. The good thing about being the first the crash test dummy for this program, when David Rich was chair and decided that it would be a good idea for us to have a formalized track, is that I've gotten to see sort of the iterations and the concepts and the things that have sort of worked, and I was sort of starting out all by myself, and now we've kind of built up to a really great cadre of people in the program, but also sort of supporting the program, people who have graduated as Eliasberg scholars and then stayed on as faculty, and basically have become our sort of stable of mentors and research advisors. So when you're joining this program, you get a sense pretty quickly that culture is very important. And I think in the Eliasberg program, that it is sort of a microcosm of that, since it really was really an offshoot of the residency, and just kind of like a cool new thing we were going to do. And now here we are, many years later, and it still seems to work. So we have a clinician scientist training program named after the first chair of the department, Bernard Eliasberg. So if I say Eliasberg Scholars, Eliasberg program, that just means our formalized clinician scientist training program. We don't have it start before you start residency. So, many programs do this different ways, but we don't have you sort of check the box today and then say you want to be in Eliasberg day one. We first and foremost still need to really train you to be top tier clinicians. And I think too often with the sort of other paradigm, you might give people who need a little bit more time in the operating room to sort of figure out what it means to be an anesthesiologist. You might be doing them a disservice by taking them out of the operating room so early, or on the back end, tying them to a fellowship that maybe they don't really intend to do, whether that's like sort of research or research adjacent. So our program starts sort of generally in the intern year, more with people being interested in the program, and usually I'll kind of say hello to the interns when they do their orientation in July, and one or two people that year will kind of find me and be sort of a little bit interested and maybe on the horizon. But we really don't put out applications for the program until October of your CA1 year. So I just sent the application out like 2 weeks ago. And that's when we actually solicit applications. And then we'll usually get a lot more people who will sort of come out of the woodwork, so to speak, and actually have an interest in research. By November 15th, we have all the applications, and by the mid-December, we're making decisions, usually on somewhere between 3 and 5 residents to join the program every year. So that first year, it doesn't really start until January 1st. And then you're fully enrolled in the program after that. So if you think about it, it's really just a 2.5-year program. But within that 2.5 years, you are afforded up to 9 months of non-clinical time. And also your time is paid. So we do a $20,000 a year stipend. So it's $10,000 for your first year because you're really just there for a half a year. And as a CA2 and a CA3, there's a $20,000 stipend, which in a way is sort of designed so that you don't feel as compelled as many of your colleagues will to sort of do post call, late work, because people, Manhattan's expensive and people want to make extra cash, and we think you should be allowed to do that. But this is meant to sort of offset that a little bit with the full sort of acknowledgement that most people involved in research are doing quite a bit of work post, and on call. So we don't want you to have to do all this extra clinical work on top of your non-clinical work. And so this is designed to sort of offset that. You'll be part of sort of a family of mentorship. So with me just kind of doing, unless I'm your like primary mentor for like a project, or 2 or 3 or 7, I'll be sort of the overarching mentor to help you smooth things out with just general logistical things, IRB conundrums, and all of that kind of stuff. But you'll generally have a primary mentor in the department, who they themselves are clinician scientists, an anesthesiologist, but also a researcher, and whether that's in pain or whether that's in cardiac anesthesia. And then potentially, depending on the kind of work you're in, co-mentors or mentors outside of the department as well, whether they're in the basic sciences or the like sort of informatics houses that we interface with quite a bit. So that's sort of, I guess, the very, the very superficial sort of like overview of what we do. I would say we're very proud of how successful we've been able to be with a program that is sort of exceedingly short. As I mentioned, being a 2.5-year program, our grads of the program have, many have graduated and stayed here to serve as mentors and really top tier researchers themselves, but many have gone on to other great institutions and had a great footprint in research, whether that's in fundable dollars or that's just sort of impacted their program. We recently were able to sort of pull off a bit of a coup and steal back one of those people from UCLA. Ira Hoffer graduated our program, went to UCLA, built their entire informatics system when he graduated because they were still on paper records. And so he's obviously like a data guy, and we were able to steal him back. Actually, he works like 90% remote. So he still lives in LA, and he flies in like 1 week in 6. And he has, NIH money for all sorts of cool machine learning, AI kind of stuff. Mike Mazzefi was one of our, I think, real like great early achievements. He's a really strong cardiac clinical trials guy now at UVA as their vice chair for faculty development. Tom Joseph, a mechanisms of anesthesia guy who works with Rod Ekanoff at UPenn. Lots of other great folks. But I think, overall, we're just very proud of all the work they've done independently. And so at the end of the day, I always tell people who join the program, it's very much a choose your own adventure. We try to support you in whatever kind of path you're on to do. And it's meant to give you the tools so that you can have a career of your own. Too many of these programs, in my estimation, just sort of say, yeah, kind of come into the department, join so-and-so's lab, and kind of the way it works is you just wait for that person to retire or die, and then you one day will be like a researcher of your own, on your own. And we kind of don't like that. We just want you to sort of feel like, day one when you finish, you're ready to sort of establish your own pathway, and I feel pretty confident saying that that's what we've instilled in our grads of the program. That said, the research climate and funding and stuff in anesthesiology is always going to be challenging, but we've always been a really strong informatics place. We've always been a strong translational science place as Sinai in general, and as part of I'm the vice chair for research here. So, big strategic plan for me when I took that role 4 years ago was to build those things out above all else, because that's sort of where where the money is, but no, it's really where the future lies for research in anesthesiology. And I think we're making really good inroads there, and we're attracting, I think, better and better people into the research track along those kind of interests. So that's my brief spiel. Probably we're not doing questions, Adam, but if I would imagine in this setting, but if everyone should have my email, I'll put it in the chat. If you have specific questions, feel free to email me, and I'm always happy to jump on a phone call individually, so that we can just kind of chat about more specific questions. Let me put this up here. Did something pop up in the chat? Yeah. Okay, cool. And with that, I'm going to hang up, and John Gall is behind me as my office mate, and I'm sure he's going to sign in and talk to you about clinical, what is it? Leadership medicine track, something like that. John will explain. All right. Bye, everybody.
Follow the money.
Yeah.
I think that's, and just to do John a service again, John joined us. His dad was a leader in a private practice, and really, John created a very unique novel niche. I guess novel niche. Yeah, that's not redundant. And followed a career path that most of us would not even dream of, and that's why we chose medicine, is because we didn't necessarily want to deal with the business end. And I think obviously a lot of people have seen the virtue of that, and there's a lot of we deliberately go after joint degreed students who have MBAs, but a lot of people don't have a vision of what to do with such a thing. And John had a vision for himself and actually developed and chose to get an MBA when he saw that his career trajectory was to work within the economics and the economic well-being of an institution, and never, ever, ever leaving money on the table, and always squeezing the lemon as tight as you can, because the business of medicine is pretty bad and costs are high and reimbursements are low, and never be on the receiving end of being devalued. And John really has made a career out of advocacy, leadership, and understanding the finances, and at an institutional and system-based level has really facilitated not only our department's economic well-being, and why we're generous, because that's our DNA, and we are generous for our residents in terms of your careers, et cetera, because it pays back in magnitudes. It's a great investment. But if you didn't have the funds, there's so much generosity that you can have. And so John really has been instrumental in making sure we squeeze every lemon, and the institution has seen the virtue of it, and that's why John is involved in the system level. And we envisioned creating a leadership track always. The GME had created an infrastructure of education and leadership, and so we ponied on that. We piggybacked on top of that and created an infrastructure to create a supervisory role. And again, John will talk to you about the different aspects of that track. But there were definitely people that had led that, where they did the education and focused their research on either finance, economics, efficiency, safety, quality, all the sort of the metrics of leadership and management, while also being involved at advocacy for our patients and for our specialty. So without further ado, John.
Thanks, Adam. I'm gonna try and live up to that intro now. Thank you. So I was well, I'm pointing that way because we share an office. He was right over there when I was on mute before. So I was just a couple years behind Sam. I think this is my 13th year on faculty here. This track is, as Adam was just alluding to, it's called the Clinical Leadership and Management track. So I usually refer to it as just CLMT just because it's faster. But so we follow a similar cadence to the application process and the acceptance process as what the Eliasberg one does. So Sam usually sends his out a couple weeks before I do. I'm probably going to send out the application for CA ones to apply probably by the end of the week. Give them about a month to get the submissions in. And we make a decision by mid-December as well to then get you into the track by January 1. We usually take about 2 residents per year. I've realized that 2 is probably like the sweet spot for those to go into this, mostly because of opportunities we want to try and provide for you during the track, but also my bandwidth as well. Taking many more than that kind of goes beyond where I can actually provide a valuable amount of time with you then as well. So let me just try to introduce a little bit more about myself. So in addition to being a clinical anesthesiologist, obviously I'm in the OR today doing cases and stuff. I've got 2 other big system roles. So I am our Assistant Medical Director for Facility Revenue, Integrity, and Optimization, which is basically just a lot of big syllabic words that essentially mean that I try and help our health system get as much money as possible out of every patient that comes through the hospitals. I do that not only for Mount Sinai Hospital, but for all 8 of our hospitals. We've got a couple different initiatives that we call them clinical revenue initiatives. One's around newborn nursery, another one's around hiring dietitians to help with malnutrition diagnosis. I've hired about 8 PACU PAs that then help us with our documentation and coding for every one of our surgical discharges. We've got nurse practitioners to do troponin rounds to help with the cardiology service. A bunch of these different clinical revenue initiatives where I basically engage with and use my credibility as being one of the people who also still wears scrubs, writes all these notes in Epic and et cetera, try and get adequate buy-in for all these different initiatives and help generate some more revenue. The other big role that I have is our Assistant Medical Director for Offsite Ambulatory Surgery Center Anesthesia. That's been coming together, probably been taking up the most amount of my bandwidth lately. We just opened a new ambulatory surgery center on the west side, 54th and West End. That's doing mostly orthopedic, spine, total joint, sports medicine, and some breast surgery as well. And so that opened on September 19th and it's starting to ramp up with their caseload. We've got another one opening up in the Flatiron district. It's literally called Flatiron ASC. And that one's doing more ophthalmology, ENT sort of cases, and taking some of the ambulatory footprint that's at New York Gyn Infirmary, which is another one of the Mount Sinai hospitals. And we've created essentially a sister anesthesia department that's going to be semi-private, semi-academic, to be a complement to all the different academic work that we do here, while also being able to expand into the New York metro area as the health system starts to expand further their umbrella of different locations and stuff. This allows us to basically provide the anesthesia services at all those different areas and do so in an agile format that allows us to also have some of our faculty do a day or 2 a month at one of these ASCs, as opposed to just being on the call schedule and stuff. It gives you some more diversity for your own endeavors in as well. In addition to that, I've got a couple leadership roles with the NYSSA and ASA. So NYSSA is the New York State Society of Anesthesiologists. For about 6 years in a row, I was the chair of the Governmental and Legal Affairs Committee. That had me on the executive council for the NYSSA as well. And in doing so, I basically monitored all the different legal and regulatory things that were happening inside of New York, and was kind of a bit of a liaison for that for my department, the health system, et cetera, to keep track of different things that were coming through there. I then transitioned. I'm now the director from New York to the ASA board of directors. And in that role, I kind of in the main New Yorker for ASA, essentially. Within the ASA, the American Society of Anesthesiologists, I'm the chair of the Committee on Economics, which is the one that helps write all the crosswalk and CPT codes and relative value guide for how we get paid. We've got work groups on there that deal with Medicare, Medicaid, commercial insurance, No Surprises Act, alternative payment models, et cetera. All those are ones that I've shared in the past, and now they kind of all report up into me. And you can see now that if you even go to like the ASA webpage, they now have picture of me running a panel on like the ASA landing page right now. So payment and all the things that kind of go along with it or whatever is a big deal, and all kind of comes through the Committee on Economics, and that's the area that I've been working mostly on. And so I try and take a lot of that experience and bring it over to the CLMT residents then too. So we're gonna, although some of these things around billing and advocacy and those sorts of things are part of the ABA curriculum that you're supposed to be going through, we try to take it to a little bit of a different, higher level than that. Not just the superficial stuff. I like to understand not just how anesthesia billing works, but how it works when the three main areas of payers too: Medicare, Medicaid, commercial insurers. What is it that Medicare Advantage actually is, managed Medicaid, having a better nuance and that sort of stuff. Alternative payment models like bundles, accountable care organizations. When it comes to how the hospital gets paid, how the ASC gets paid, it's important to understand how codes and coding help make up all those different dynamics. And I try to provide you all with a different way of looking at every sort of encounter that comes through the hospital or an ambulatory surgery center, and how the money flows, and how that, a common cliche within our Committee on Economics is that the answer is money. What was the question? And so some of those similar things can happen inside the clinical setting, inside of basically everywhere within, any health system, including ours. As you're part of the CLMT track, there's kind of like five main things to a well-rounded anesthesiologist. There's the clinical part, the education part, research, administration, and advocacy. So we're going to focus a lot on advocacy. At least one of the years while you're here in the CLMT track, we're going to try and make sure you get to the NYSSA Legislative Conference up in Albany. That's usually the first or second Tuesday of May. And then also to the ASA Legislative Conference down in DC, also either the first or second week in May. That's usually like a 3-day conference. And we'll go and visit Senator Schumer's office and Senator Gillibrand's office and see some of the other Congress members of New York when we go down there. There's other sorts of networking that happens in all those different sort of settings and too. And so that allows you to try and, start building your network then as well in those different sort of settings. We'll also kind of tap into more like the financial and the innovative part of it too, by making sure you go to at least one of the ASA Advanced conferences. That's been rebranded the last couple of years. It used to be called the ASA Practice Management Conference. We've kind of, now the ASA Advanced Anesthesiology Business Event, which is when that, if you go to that landing page, that's where the picture's from. And so during that one, it's a lot more of the other nuances that deal with like clinical operations, practice management, the finances, but on the other side of it, billing services and all the different payer things and stuff. And so getting it to attend one of those conferences is also, rather important when it comes to this track. And we try and give you a different feel to it than maybe any other residents that would be going there. And that when you do go, I'm going to have you essentially shadow me while we're there. So instead of just kind of going there and, trying to get like 10 or 15 hours of CME or something like that, we're going to go to some lectures together. We're going to pick out which ones that you seem to have the most interest in, as long as they're not conflicted with one of my own speaking engagements. We go together and we, basically experience the lecture, ask a couple of questions and stuff, and then we get to kind of debrief afterwards of, so they talked about this when it came to this thing that's happening like Wisconsin or California. This is how it's happening in New York. This is what we've done about that at Mount Sinai. Or we haven't started doing something like that. This might be a great thing that maybe you want to look into, and we can bring back to Mount Sinai and, find you some time and some resources to try and pull a project like that off. So those sorts of opportunities are then ones we try to build on and try and make it a conference experience that's, different than you might get from some other program then as well. And when it comes to the innovation side of it too, we've got as Sam was just mentioning, we've got a pretty robust amount of clinical data scientists inside of our department too. And so if you're, more interested in, either artificial intelligence, machine learning, you got an invention, you're innovative in some sort of way, whatever, we've got ways to facilitate that then as well. So I don't have to be your mentor when it comes to the clinical leadership and management track. If you want to go more into like the quality and risk side of things, we've got mentors within the department that can do that. One of them is our system officer for patient safety, who's now also taking a role over perioperative medicine. As I mentioned, we've got someone who leads our our clinical data science team as well. And so whatever your realm of leadership and management might be, we've got a mentor for you. And I'm going to work to help coordinate your involvement with them. And then maybe they, if it's not so much in like the financial or economic side of things, we've got someone else that can help mentor you through that then as well. And we'll set up monthly meetings for you then too. So because we enroll you in our GME office has a leadership course that meets about 1 or 2 Fridays a month for about 9 months during your CA1 leading into CA2 year. And on those days, I'll have you set up one-to-ones with me as well. So you go to class for a few hours, you're going to get some projects associated with that class, maybe a capstone project too. And then we do one-to-ones that kind of start off as being more of let's hear more about you. What are you interested in? What do you want to try and go into, whatever, to you're going to start on this project. Okay, let's talk about how you want to go about doing that project. You want to try and engage the key stakeholders, do some change management in these areas. We're going to, draft up some emails to some important people here in the system. Okay, you want to like run by some drafts of those emails with me so you don't, trip over yourself with those sorts of things. All sorts of areas that kind of help advise you along the way to, more successful ways of going about all these different things. And you kind of turn into that yes person where like you pull off one project, it goes really well. Hey, you seem like rather capable. Let's try and ask you to do something else. And then all of a sudden you got 4 or 5 things and it's managing your bandwidth and figuring those things out. And all those different things are ones that I want to try and help you with along the way during like those one-to-ones we have each month. And they eventually, transition from CA1's year where we're trying to figure out, what is it you're interested in to CA3 year to figuring out like, okay, how to carry these on to like your next couple of years and your early on in your career too. I spoke rather quickly. I know I went through a lot of different stuff there. I'm going to do the same thing Sam did. I'm going to leave my email here in the chat. And feel free to email me. I always get a couple emails from people after this as I type my name. And if anything comes up, please feel free to email me. Happy to answer questions and stuff, give you some more information about things. We've had, this is maybe our 5th year of doing the track. We've had a lot of success with it. People are very interested in it. I think some people, come here, I mean, for Adam, but also for me a little bit too, because they want to like fall into this sort of track and get into the advocacy. And we have one right now who's in the track. She wants to be a politician and she's got her eye on the prize there. So we've got her set up with she wound up getting accepted to the ASA policy research rotation, which I think she's going this coming spring down in DC, where she spends it with the ASA lobbying team, goes to visit legislators at their different fundraisers and stuff. And we've been working on that for a couple of years now to ensure that she was going to get that spot, bringing her to the ASA Legislative Conference, introduce her to the Chief Advocacy Officer, Manny Bonilla and Nora Matus, who, run ASA's lobbying firms and stuff. And so it's those sort of connections that we're going to try and facilitate to try and, engage in that success for you then as well. That is my.
Thank you, John. And while we just have a few more moments, just as an offshoot to what John was saying, and there was a time where I put my finger on the scale because we noticed that our residents weren't doing disparity research, and I sort of suggested that any of the residents interested in doing disparity research might have a higher likelihood of being accepted to the Eliasberg project and scholarship, which then became an offshoot to our diversity, equity, and inclusion track and our leadership track. So not only those residents are afforded the opportunity to take the GME leadership educational program, they're mentored by Chantel Pyram, who heads up the NYSSA ASA diversity committees and is integral in those tracks at the local and national levels, and for residents that have a unique interest in developing projects, opportunities, research in disparity and diversity, and becoming an expert and a leader in diversity in healthcare is unique. And Javon Porter is our first DEI resident who's actually joined and is working on projects with Param. When someone didn't have a form-fitted sort of leadership role, but had an MBA from Wharton, Phil Susser came, and it didn't form fit with John's idea of what leadership was. I just couldn't sit on the sidelines and not give Phil something. And actually, Phil's interest was looking at innovative product design. And so his whole project is working on wireless ECG leads and whether they can be commercialized and validated and then brought to, like I said, to commercialization. So we invented a subset of the leadership track which then became the innovative and entrepreneurial track. And Matt Levin oversees that and is interested in developing techniques and technologies. And Misha, one of our CA2s, also enrolled in that track as well. And from the offshoot of that, we already talked about, we've always had, in fact, the very first scholarly track we ever had was our education track. It really started as medical student, as a medical student rotation, and that medical student rotation, medical students would do an elective with me in simulation, and that was a great draw and a great recruiting tool to the residency, and then they would get involved in teaching, and they would be instrumental in developing simulations and carry on those simulations and educational opportunities for the medical students and then the junior residents. That developed into a full-blown clinical educator track where it was for everybody. And in fact, and it doesn't, all the tracks start January 1st of after the CA1, get your feet wet, get your game on, become superb clinical anesthesiologists. Also figure out what you want to do. Listen, you might not have ever had research, and we've just provided our residents the opportunity, will provide the residents the opportunity to go to the ASA. One of our interns went and presented. And if you have research that you're working on that gets accepted, we will send you as interns. Doesn't matter what rotation you're on. We will provide the opportunities for you to present your work. And or the advocacy, et cetera. Caroline also was instrumental and worked on committees with John and was first author in several papers so far and is a delegate to the ASA as an intern. And so she has a clear trajectory. Eunice Coe is the resident that joined us from Galveston and really had her eye on the prize of leadership and opportunities to then join. And Eunice now is the president of the NYSSA, has been a delegate, has been afforded all the opportunities, and we're very proud that she has chosen to be one of the fellows at the ASA in the governmental policies. So she's really just an extraordinary, and she's staying on to do cardiac. So we're very excited that Eunice is just sticking around. She's one of our administrative chiefs, lo and behold, as that occurred. The educator, it's a free-for-all. I'm proud to say that at least probably our residents provide about 20 or 30 different educational opportunities each and every month. For the medical students, the residents, some gravitate to be the teaching chiefs, and they oversee the educational whole portfolio of the residents. The residents provide about 80 or 90% of the medical student education, 100% of the volunteerism education, 100% of our intern simulations. You can become expert in small group, large group, or simulation-based education, now cadaveric-based education, now not just simulation mannequin-based, but virtual reality and augmented. Alex Meschel was instrumental in doing research as a medical student in simulation and has joined us and is one of our Elasbergs and is going to be probably the first time I've offered up, and this is everyone close their ears. Administrative and teaching chief rolled into one. We've tried to break these up, but we've had about 3 of those, Mark being one of those, in the past. But Alex is definitely on the fast trajectory to being both of those because he's off the charts amazing. But now we're creating a subset of the Eliasberg where there'll be a research opportunity and a funded research opportunity. As we say, we have about $100,000 worth of grant monies available per educational year, but since we've expanded the types of opportunities, I've also been able to expand the money available, and we've tried to keep it within the 20K stipend for the residents to benefit from, as Sam also alluded to. Translation, there might be something else that people become interested in, like global health if it resurfaces itself, or some other offshoot of the current tracks. Again, can't predict the future, so we just get out of the way. We recruit amazing people, and if you have different ideas for your own careers, we'll facilitate it. With that, I did go over a few minutes, so I stole some of Kirsten's time, but I don't think we sort of went into the details as the tracks as I just did. So with that, is Kirsten available to speak on wellness?
Yes, I'm here. I'm here, Adam.
So let me do another introduction. Kirsten is just an extraordinary individual. She comes from one of my most cherished institutions that we recruit chief residents from. And in fact, Kirsten was one of the last to interview. I think you interviewed on the last day, and she was
I was the very last interview.
easily one of our top ranked students, joined us as one of our chief residents. Her presence makes me feel well. And the original wellness champion was Natalie Smith, who was also one of our chief residents, who runs liver transplant. And we couldn't be happier that Kristen stuck around and has really taken the lead in wellness for the entire department, not just for the faculty, but the residents, the fellows, etc. And I will turn it over because Kristen is just the epitome of wellness. So I'll go silent.
Thank
Your
you,
internet,
Adam.
it's
I'm going to share my
sucks.
screen.
It's not.
See if I can make this full screen for you guys. All right. So thank you, Adam, for what is such a nice introduction. Oh my goodness. Like he said, I did my residency here. I remember my interview day. It was late in January, and I was dying to come here. And I'm so happy I ended up here. Really wonderful experience overall. And they couldn't get rid of me. I stayed as an attending, and now I've been a general attending here for the last 3 years. Natalie and I sort of split the wellness champion position my first year, and now I'm doing most of it, and I can explain to you what the wellness champion is and sort of our goals and our curriculum around wellness here at Sinai. So really what my job is to be a point person for all of you, for all things, not just wellness related, just another person that you can reach out to, ask questions. I've helped residents like make doctor's appointments when they need someone to make a phone call. Can I get squeezed in? You know, we've helped people get days off if they need days off, or figure out like FMLA and, you know, other sort of things. So kind of a catch-all. I know a lot of people around our department and within the hospital, so you can kind of connect you with anyone you might need for any questions you might have. I think Adam and all of the APDs will agree that we're all firm believers in that you have to take care of yourself first before you can take care of any of your patients. And we really want to make sure that you are all not only physically well, but emotionally well through all of residency. This is a hard job, and you know, this residency program especially, it's not a cush gig. We really work you hard. But you come out truly exceptional anesthesiologists, and we want you to have a well-rounded training, not only in the OR, but like how to manage life outside the OR and, you know, be a full human in and out of the OR. We're lucky because Sinai as a hospital system actually has a huge like well-being office. It's called the Office of Wellbeing and Resilience. Who have a ton of resources both at our main campus and at all the other campuses that Mount Sinai has. Having a big office like this is helpful because there are dedicated people for almost everything. So whether it's like creating our peers program, which I'll talk about in a little bit, or like mental health physicians and mental health professionals like social workers who are available for appointments. They have like tons of subcommittees that residents and students join for like sort of niche wellness projects. The point is that there's a lot of support from Mount Sinai as a whole, like not just our apartment, which is helpful if you're really interested in this and want to do projects or join our sort of little wellness committee. There's tons of opportunities and support from the hospital as a whole. One of our goals, you know, one of my goals as the wellness champion is to make sure you have a strong emotional support network. So these are a couple photos from different events we've had throughout the year. We have our annual softball game, which is residents versus attendings. And then the two bottom photos are our ladies brunch every year. And then the affectionately named Meat Fest, where all the gentlemen go out together, which are just great sort of resident attending bonding experiences. We also have a couple sort of wellness like mentorship programs. We pair all of the interns with CA1s. So during your intern year, you'll have like a big sibling sort of to have at least a point person where you can ask questions or say, surgery on Monday, like what do I expect? What should I do? Like where's the shuttle? So I think that's like a nice sort of pairing from the get-go. And then CA1 and 2-year will also pair you off so that you have someone to say, I'm doing an EVAR for the first time tomorrow. I have no clue what to set up. And if you don't want to text your attending, like, I have no idea what I'm doing, this is the first time I'm doing it, it's nice to have a resident buddy that you can sort of run your plans by first. The last thing we have, which is a little bit morbid, but I think it's important to mention, is we have a very strict intraoperative death protocol. And so if anyone experiences a death in the OR or a particularly challenging code, we immediately relieve that resident as soon as possible. We send them home. Everyone who's ever experienced this usually tells me that they get inundated with text messages from myself, from Adam, from the APDs, checking in, making sure you're okay, making sure you have had adequate time to like rest and sort of debrief. And we take this really seriously because we do have a challenging job, and thankfully intraoperative deaths are rare, but we want everyone to feel really well supported if such an event happens. We'll also have some opportunities for just practicing different methods for stress reduction. We want to kind of show you all the options out there and for everybody, but at least you kind of are exposed to all these different things and can pick and choose what works for you. We have different mindfulness sessions. One of our attendings, Dr. Jeff Zahn, who was with our department for many years, runs a lot of mindfulness training. And he has a great perspective as someone who was an anesthesiologist and is now sort of moved into this wellness sphere full time. We'll have like different group fitness classes, pet therapy. Sometimes we'll get the wellness group, they walk around with like a little cart with tea and aromatherapy and ice cream, and we'll try to do things throughout the year just to remind you guys to take it easy for a little bit, take a little break, and have something to enjoy during the day. This is one of our pets that came to visit, one of our many ice cream socials. Yeah, we have a lot of opportunities for kind of just bonding and hanging out during the day. When it comes to our formal wellness curriculum, the two main sort of programs we have are peers and our resiliency training. So peers stands for practice, enhancement, engagement, resilience, and support. This is a program that was designed by psychologists at Mount Sinai, and they use it for their own research, and at least since I've been a resident, so at least 5 or 6 years. And it's a longitudinal program. There's 4 sessions per year. You meet with your class for the CA1 through CA3 years. There's no attendings present. It's led by members of your own class who go through like a little bit of a training ahead of time. And they usually pick a topic, whether it is like navigating challenges and how you address challenges in the workplace, or talking about your different values. I'm trying to think of the other topics, but it's usually a pretty broad topic, and your class leaders will sort of guide you in a discussion. It's very informal. Everyone brings their bagels and coffee to it, and really just a chance to sit with your class for an hour and, you know, a little bit of a chance to vent.
And Kristen's internet cut out for a little bit. I'm just texting her. It just got disconnected, but she's logging back on right now.
You can never tell if it's you versus me. I'm literally texting Mark going, hey, was that my crappy internet or is that
I have to look around like, is everyone else not moving or is it just her? She's just logging back in. I think the internet at the hospital has been kind of weird today. Like even my phone has been slow for everything.
Oh, I saw Sam, John, and Kristen were like pixelated terribly.
Hmm.
Well, now we know that it's an official interview day because it never fails to fail. So I feel good about, I shouldn't say this. Last year, everything went without a hitch for about a second. And the minute I uttered the following words, hey, everything's going fine. We must be in the twilight zone. I lost power, internet, and cable all within like something catastrophic happened at the street level. And I'm like, and I remember texting Maggie going, I think F out of luck. And maybe and I ended up rescheduling all the interviews for the first day, but it made me feel good because I realized that life's normal. And, if things went out without bad, it wouldn't make sense. So thanks for bearing with us. As you know, this is life. And so please be reassured that if it happens to you during your interview, we don't care. And in fact, if everything goes swimmingly, we're just kind of surprised. And look
Hi,
at and
sorry. I'm back.
flexibility, no, flexibility,
Location.
resilience, wellness, teamwork,
I know.
communication,
All I had to do was run across the hallway.
all personification of the department and the specialty of anesthesiology. Yeah.
Basically, we have lots of wellness programming throughout the year. The last thing I really wanted to say is we have a lot of mental health resources that are completely free and completely confidential. We have the main one is called the Student Trainee Mental Health Center. They are very flexible with scheduling appointments. You can schedule appointments well into the evening to sort of accommodate resident hours. I think since COVID, I actually think all of the appointments are now virtual, just like on Zoom. But we also have social workers available if you want an in-person appointment. The point is that there's lots of options, and that's it. Does anyone have any questions or concerns or any specific wellness things?
Now, if you could put your email in the chat,
Yes.
if I want to ask you, I think the key point that I know gets lost without the slides is how anonymous all of the psychologic and psychiatric services are. They don't even show up in Epic. So if you end up like needing an emergency surgery and need an appy, God forbid, or whatever, it does not show up in any of your medical records at all. And I think people get very, very concerned about accessing these resources, which a lot of people really need, but are frightened that, it's sad that, someone with high blood pressure is not scared to tell anyone they got high blood pressure, but the minute they tell people they have anxiety or depression, now all of a sudden it's a stigma. So anyway, I just wanted to emphasize that.
I thought of one more thing that was an exciting update. We recently got egg freezing covered by our insurance, which is huge, and that we've been working for many years. So it's a $1,500 flat rate for your visits and then procedures. I don't believe it covers storage, but that's huge. We have been asking GME for that for a very long time. So we're excited that it's now included in your resident insurance. In general, I tell you guys this at orientation when you start here on July 1st, your resident medical insurance is actually quite good. I never paid for a single doctor visit, and I saw specialists, I saw dermatologists. So I remind you guys to really take care of yourselves, take advantage of that. And I'm sure that will be the case wherever you match. So it's just something good to keep in mind.
I can only say that every time I had an emergency or a catastrophic medical event and I was cared for at Mount Sinai, I left feeling better than ever about my institution and about the care I got. Anytime one of our residents needs emergency care or needs to see a specialist, I can't emphasize enough how the outpouring of the specialists and the physicians. One of our interns just had emergency back surgery. People would have paid their teeth to see this specialist and have be cared for in basically 2 days essentially, and got in through the opera room, and we took good care of him, and his the only thing he ever heard from us was, don't worry about anything other than you, and we'll take care of the rest. And I think that can't be emphasized. You never want to think that there's going to be a problem. You never want to think you're going to be stressed. You never going to want to think you're going to be the person that's having anxiety or having issues or depression. But you want to go to a place that the resources, your culture, your community, your peers all look after you, and the entire institution looks after you. And I can only say, when I sent the program director saying that the resident was going to be out, all they said was, "Oh my goodness, I'm going to reach out and see if he's okay." This was from ENT, the chief resident on ENT and the program director on ENT. All they did was just the outpouring of care, not, "Oh, he's missing X," or "How is he going to make it?" That wasn't even in in anyone's neurons in their head. And the same thing for having to adjust to schedules and schedules that are coming up on surgery. You think you're joining an institution and you're going to be rotating. And I used to say early on, I was very concerned about having an internship, because you're having your children play in someone else's home. If anyone has children, you know what that's like. You don't know what they're going to break, and you don't know who's going to touch them inappropriately. So I didn't want to have to deal with that stuff. I can't be more proud about how people embrace our interns as their own. And they're never like the intern, floaters, they're just anesthesia. It's never the case. You're part of the institutional family, and you always will be cared for. And I can't be more proud of it. Makes having our interns here just magnitudes more, wonderful.
You make so
Not
many
only
friends your intern year. It's amazing with all the different departments. And Adam actually witnessed this just a week or two ago. I went to one of my ENT friends and I was like, "I think I ruptured my eardrum. Can you look in my ear?" To this day, and just like curbside your friends, and they're always willing to help you. And like it extends well beyond residency. So
and
it's
it's so
great.
because you're not Hey Anesthesia, you're Kirsten.
Mhm.
And to debunk all that nonsense about, if you've ever heard anyone say, "Hey Anesthesia," you talk about macroaggressions and microaggressions. That's a microaggression, because basically it relegates you to not even being a human, not even being a doctor, not even being on a peer result. Don't let anyone call you "Hey Anesthesia." And setting it up from the beginning with the relationships, it does diminish a lot of that. And you take for granted this "Hey Anesthesia" thing like it's nothing. It's really, "Oh, hey Anesthesia, you ready yet?" And you're sitting in front of a patient. What does that patient think you are now? It really is quite meaningful. So again, don't let anyone diminish you by labeling you as a thing. And I think the setup of the relationships with your peers on medicine and surgery and ENT, and within our department and at the leadership levels at our institution, just set the standard of who the anesthesiologists are, because we're basically running it all. And it really becomes important, for your well-being and for the respect of the department and the collegiality and the camaraderie and the conduciveness to you being someone in training that's learning, and that it can't be understated.
And
So
one other thing for the wellness, I don't know, you mentioned the 4 wellness days that you get
Oh, yeah.
per year, to manage your doctor's appointments, your family's appointments. But I will say, like, even before, I was a resident before wellness days existed, and Adam kind of, I think, invented wellness long before it was a thing, when it was just considered coddling, because he made sure that the residents were always taken care of. I remember as a resident, life happens. Friends and co-residents who had deaths in the family, births in the family, they had divorces happening, marriages happening, all this stuff. Life happens when you're a resident, and it doesn't just go on hold. And so sure, wellness days are great and will exist, but you come to us, you come to Adam, and we make sure that you're able to take care of your life too. I think that's one of the most important things, that even before this was a structured program, 30 years ago when Adam started doing this, he made sure that as a resident you were taken care of, and that's kind of the heart of the program too. So you have that family that you can go to. Like Adam mentioned, like even the intern who just recently had surgery, like has been able to come to us and made sure that everything's taken care of, and has made sure that he doesn't have to worry about all the other stuff too.
We know how challenging residency is, and we want you to be challenged in a good way. You want to be built up, not beat down. And knowing that you have all the support to be the best doctors you can be is the most important thing that we've established in the program. So, and again, having what I'll tell you, with all of this other stuff that the ACGME and promoting wellness and lactation rooms and time off and the ability to have a baby and not, delay your graduation and blah, 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 and work hours, I'll tell you, I used to battle it every single day. And now, shockingly, I've got all these allies to make it really easy. To make sure that the residents are cared for. Whereas, like Mark said, and I used to joke, what they used to call coddling is now called wellness. And, taking care of your own is just like, it just shouldn't be surprising that we're going to. So again, Kirsten, thank you. Thanks for being resilient and
Thanks for the quick change here.
wasn't well, your internet.
I did a little jog. I feel good now.
That was truly unwell. So in the last few minutes, I'm going to try to tackle any things that might not have been addressed up until this point. It's sort of a rapid fire question answer to myself. And so I'm going to go for it. So in the entire time I've been running this residency, up until maybe a decade and a half ago, our residents parlayed out to a third. What do they do when they graduate? A third, a third, a third. A third did private, a third did academic, a third did fellowship. Over the course of the last maybe less than a decade, it moved to about 70, 80% fellowship, which is all national stuff. And now we're seeing, because of the on fire job market, we're seeing more and more people going right into practice. So we're about a 50% of the fellowship way. And we've provided you, I believe, the list of where residents have done their fellowships for probably a decade and a half, and you get a sense that not only are we proud that people want to stick around in our fellowships, but that they get the top fellowships wherever they want to be in the nation. You've heard a lot about our clinical and our didactic, and one would wonder, well, does this work? Yes, this works. We have nearly a first-time taker board pass rate of 100%. We reward excellence. How so? We reward the boards actually cost $875 for the basic, $875 for the advanced, $24.50 for the applied, which is the oral and the OSCE. I can only imagine by the time you're sitting for it, it's going to be more, because that's the way life is. We will pay your boards if you perform at a certain level of your in-training exam. So as a CA1, if you get a 75th percentile and above for your in-training, we'll pay for your basic exam, $875. You get 3 shots at that. If you take the basic exam and get above a 10% score, we will then reimburse you for your $875. As a CA2, if you get above a 75th percentile, we will reimburse you for your basic if you hadn't already been paid for it. As a CA3, to keep encouraging people to read, if you score at the 75th percentile as a CA3, we'll pay the advanced exam. That's $875. Here's the true bonus. If you stick around as a fellow or as a faculty member, we'll pay the applied exam as well. And that's another $24.50. All told, it's over $4,000 worth of benefit for performing admirably on your in-training exam. That 75th percentile, 95% of our residents meet that. And so this is not a number that is unreachable. It just happens to be the cut that if you get 75th percentile, I've never had anyone fail their boards. And so it just, that number's it was sort of landed upon. We also reward excellence, as was mentioned, with meetings and meeting reimbursement. So if you are prolific and you are publishing and presenting, we will continue to pay for those meetings, etc. Uniquely, I can't imagine this is happening anywhere, but we keep re-looking at the benefit of the meeting reimbursement for our faculty, and we duplicate it. The exact number money that we pay our faculty to get reimbursed for a meeting is the exact money we pay our residents. And it depends on how long you are at the meeting. So if it's 2, 3, 4, or 5, I think the max now is like $2,700 or $2,800 if you're going on a meeting. You can go internationally as long as it's a presenting meeting. So if you are presenting or going, if you want to go anywhere, Europe, etc., we will pay for it. The GME throws another perk. What's that?
$3,000 now, plus the $500 you get from the GME you can do one time.
So the GME, each year, the GME throws another 500 on the pot. So between our reimbursement and the GME, it's a $3,500 reimbursement for each meeting. That's unbelievable. When you're talking about resident reimbursement. That also, while on the heels of the international meeting, the Zambia meeting we do every year because we're part of a consortium to supply international opportunities in Zambia, because we saw after COVID, everything just disappeared, and we wanted to reestablish how prolific we were in international and global health for our residents. So we started we joined in on the Zambia consortium. We treat that exactly like a meeting. So actually differently, no out-of-pocket expense. We cover the entire thing, given the fact that it's really expensive to go to some of these off the garden path places. And so, travel, et cetera, insurance, et cetera, healthcare, et cetera, that you need to prepare, and the infrastructure, we pay for everything. So you're left unaccounted for. If, however, the international mission falls apart because the world is not safe, we will hold you unaccountable. So if you are not allowed to get on an airplane or you don't go, we will reimburse you so you're not at a loss for those out-of-pocket expenses that you need to prepare for, and that becomes invaluable. Do we have any CRNAs? Yes, we have 24 CRNAs. Our problem is that our CRNAs are union. They have a 3-year contract, and just like the finances for anesthesiologists, the CRNAs also have their own exponential rise in salaries, and that's also exploding for them. So every 3 years we renegotiate the contract. We have a wonderful place to work with our CRNAs. So we just went from our 16, we're up to 24 CRNAs. I oversee the CRNA program along with Carlin Moran, who is the lead CRNA. We do not have a chief CRNA. We do not have an administrative CRNA. That was done deliberately, and I oversee the CRNAs. The CRNA schedule is made by us. So we make the CRNA schedule, and the CRNAs are not allowed to do any cases that the ACUGME says you have to do. So it's off the table. So they're not allowed to do cardiac. They're not allowed to do thoracic. They're not allowed to do the transplants. They're not allowed to do neurovascular, or any of those kind of cases. If there's an awake intubation, they're not getting it. Residents are not allowed to be supervised by CRNA. So if you happen to be a CA1 and you're being supervised by your preceptor, and they have to cover another room, and a CRNA gets moved into that room, we will move you elsewhere. You are not to be supervised by CRNAs or educated by CRNAs. And our CRNAs understand this. We have also a wonderful working relationship with them. That's how we get all the residents to the ASA and the PGA, which is the postgraduate assembly. Sorry if you're into golf, it has nothing to do with that. But we have the second largest meeting in the United States in our backyard every December, and a lot of it has jump-started people's interest in doing research and being academic. And in fact, all the interns on POCUS, anesthesia, pain, ENT, peri-op, all those interns will go free to the entire PGA, as it happens to be worked out. In fact, the internship schedule is predicated on your vacation requests. So it sort of isn't, oh, let's pick these to get that. No, it's based on what you want. In fact, every schedule is made on your vacation request up front, and then we build the schedules around that. So it starts with you, and then we build it. But if you happen to be on those rotations in December, you get to go to the PGA, which is Friday, Saturday, Sunday, Monday, and Tuesday. And Eddie Cohen, who's one of the world's authorities in thoracic anesthesia, has a thoracic symposium, and you can go to that for free too, which people pay unbelievable money for that. But it's a major academic meeting. It's a huge perk if you're thinking about different cities to be in, but to be part of the New York State Society of Anesthesiology and the PGA is pretty rocking. Carlin always reminds me, hey, what are the important dates that we need to beef up our CRNA numbers in the operating room so we can support the residents? So all the residents get to go to the graduation party. And so we relieve our residents to go to the graduation party. The CRNAs come in. The CRNAs, some work till 5, the majority work till 7. So sometimes you're relieving them, the majority of the time they're relieving you. It doesn't matter. It's a very collegial camaraderie where everyone works together. And like I said, it really helps because I oversee the recruitment and the oversight of the CRNAs. And guess what? I make their lives as wonderful as I make the residents' lives. And they really appreciate it. And they come to work and they're very nice colleagues. And there's no politics, even though there's lots of politics that surround CRNA programs, et cetera. We don't have it. At Sinai. Our GME is actually kind of extraordinary. We're an incredibly generous department with the perks, the benefits, the opportunities, all of it, the travel, the reimbursements. Many of the institutional programs use the very generous GME perks that supply all of their perks. Well, we just piggyback them. So along with the $500 annual, they have like almost an $800 or $900 food allowance. There's 100% free shuttle systems that take you back and forth, and it's predicated on the schedules. There is a car service, an Uber car service that gets written on. There's parking opportunities for the residents if you happen to have cars and you're going to the different environments. Those are all sort of things that are built in, and there's educational opportunities. Like I said, the leadership program, it's not that we have some of the residents that aren't part of the track and are going to be enrolled in that educational opportunity. They're very well versed also in making sure our residents, and we are too, making sure our residents can be part of the root cause analysis, and also the GME analysis and the team approach and the different site visits, et cetera, from the ACGME, and they get our residents, and they know why. They look for anesthesia residents because we get our residents out to participate. So they know that if the residents are involved in these committees, that we'll actually support them and have them available so that they can participate for their own education. Does Sinai have housing? Yes, we have like 16 or 18 apartment buildings subsidized in the New York metropolitan area. It is lotteried. It is very nicely subsidized. They're big apartments. They're in the New York, the Upper East Side. Is it 100% guaranteed? No, no one tells you, no one should tell you that, but 100% of the interns are offered housing. The interns have the highest priority of getting housing. And so the opportunities do exist. And I think Maddie supplied you guys maybe the price lists and et cetera. Is it expensive to live in New York? Yeah, it's expensive to live everywhere. I actually don't think New York's the most expensive city anymore, but can you afford to live in New York? Yes. Do we allow moonlighting? No, we forbid moonlighting. Here's a wink. If you can't see it in the virtual environment, we don't call it moonlighting. We call it a bonus for extra work. I used to say $1 million, but there's about $1.4 million worth of supplemental income for our residents to capitalize on. And in fact, we just enriched it a few days ago. So the way we do it is we automate it. And so that if you're on the comp record past 7 o'clock, you automatically, it used to be 7:30, now it's 7 o'clock. You get $400 in your paycheck. You don't have to do anything. You don't have to document anything. It happens. If you happen to be doing out of operating work, like doing PACU turnovers or taking care of a sick patient or transferring someone or hanging out in the PACU and handing off, then you just put in a handwritten request and we approve it. If you're doing cases past 8:30, you immediately get $600. Every moonlighting opportunity is about $100 or a tweak more per hour. We don't do it by hour, we do it in an allotment. So we cover Saturday weekends at Elmhurst. We cover OB on Saturdays, and there's like a second shift to do epidurals and C-sections. If our resident call is identical to our faculty call, you work late the night before call, you come in at 4 o'clock to a Zoom call. If you want to work 24 hours, which every other program has, we'll actually pay you $900 to come in at 8 o'clock and work from the 8 o'clock till the 9 o'clock, and then take the call. Some of our teaching chiefs will teach post and then get post call dollars. Some will teach pre-call and get teaching dollars. So there's actually opportunities. Not only do we reimburse you for clinical work, but we'll reimburse you for teaching, whether it's medical students, whether it's interns, etc. So there's plenty of ways of making sure that you can supplement. You can volunteer for it, or you don't need to, or don't want to. And then there's plenty of residents who are interested in doing it. We provide the pre-call, or the short calls start clicking in at about the second week of your CA1. Once you're starting to be able to be double covered, then I give the nod. It's usually right before I go on vacation, which was the last 2 weeks in August. It just seems to be routine. And I give the anointment, and now the floodgate is upon us, and our CA1 start doing the supplemental income. And I will tell you, while it's supplementing your income, it's also supplementing your ability to do cases, because it's really easy to get and you're doing more of the same. And if you happen to be in a very long case and it's ideal for your education, you'll get compensated for it, for staying and seeing the continuity of care and the emergence of the patient, etc. It's a win-win-win-win-win. It makes all the sense in the world. The other benefits that we will give, we were the first ones to ever give an iPad. The very first iPad iteration that we were giving out, it became apparent probably over the 7th iteration of the iPad, or the 10th, I can't remember, when we stopped it, is that if people wanted to use iPads, they would have done so. And what we ended up doing is we took a poll and a survey of the residents. So now the residents all get TrueLearn. Everyone was enrolling in that, so we give them the TrueLearn educational bank, and you get other perks like a thyroid shield. So you get things that you could just keep in your pocket that cares for you and your patient. So a thyroid shield, and pulse oximetry, and neuromuscular blocking monitor. There is an educational stipend from the GME, and what we have done is that if you want to spend that once the first year you're here, you can actually buy your own full lead. And so that's portable, and you could take it with you. And we've worked out deals with the lead company, and there's the lead tailor, I don't know what else to call them, will come in and measure you. And we've worked out the deals so that you guys can get your own lead if you want to use the educational resource, given the fact that we provide you guys all the educational and the resource. Now you have a supplement to be able to buy your own lead if that's something you'd want, and then it's portable and you could take with you to your future jobs, because a lot of anesthesiology environments happen to be radiating environments, off-site, small rooms, EP, endo, IR, those bronch, those tend to have, radiating types environments. Everyone wants to know what my plans are. I don't know. I got it good. Here, if past track record is any sign of future performance, I did medical school at Mount Sinai from 85 to 89. I did my internship in internal medicine at Mount Sinai from 89 to 90. I did my anesthesiology residency from 90 to 93. I did a year of cardiac from 92 to 93. I was a chief resident in 92 to 93. I stayed on faculty at July 93 was my first year as faculty. I took over the residency program in 97 and have been running it continuously ever since. We have a full accreditation, no citations. Our last review was 2010. And so at some point, and I sit on the resident review committee for the ACGME, we're going to have a site visit, maybe within the time frame. They keep saying it's going to happen, but because of all the delays and the new accreditation system, and then COVID hit, now they're starting to have about a few percent of anesthesia programs are being reviewed. Maybe we'll have one. I always said to everyone, if we get anything less than full accreditation and no citations, I would hurl myself out of the window. We used to be higher in the department, so this doesn't make, I'm only a second floor here at my house, so that's not that credible, but I will swear we are going to have nothing less than full accreditation for the program. And in fact, just as a sign of how well received our program was. Even back in 2010, we were approved for a 33% increase in our residents from 18 to 24. And then we just got approved this last year to go from 26 to 30 residents. So we increased our residency by 4 a year. And that's basically the only way that happens is if you have a full accreditation and no citations and no areas for focused involvement. So where am I going? Who would tolerate me, first of all, and why would I tolerate anyone? It's really kind of wonderful to have the unwavering support, and I have lived through 1, 2, 3, and living through a 4th chair, and at no time did I feel like I had to battle to support the residents. It was always, yeah, that makes sense. Yeah, that's right. Yeah, that works out. Yeah, that's cool. And it's such a reassuring environment because everyone has such pride in the residency and understands the virtue of training the next generation of anesthesiologists, not only for our department and our patients, but the future of the specialty. And it really makes my job kind of remarkable. And it's even pretty wonderful to just even being on this meeting, and everyone you've met were our residents who have done just extraordinary things with their careers. And I can still remember interviewing them and having them join as interns. Well, Sam wasn't an intern. He started before internship even existed. So that's how old he is. And it really is kind of remarkable to see the trajectory and each one has taken their own pathway. But I literally was able to watch that pathway and the trajectory, and it's pretty remarkable. Why would I ever want to give that up? So with that, I want to thank all of you. I know we went 15 minutes later. I apologize for that and stealing 15 minutes of your life. I hope it was worthwhile. And with that, we thank you for spending so much time today and so much time in the future getting to know us, and we look forward to getting to know you. And if you have any questions, you can always reach out. You have those 3 emails. You'll have Mark's email, or you can always reach out to Madeline. You'll start getting information about the interview day, but please remember, you can wear scrubs. That's not a joke. It is not a scam. We want you to be as comfortable as physically possible. This is not a beauty contest or a fashion show. This is hang out and get to know us and let us get to know you. And that's really the whole premise of this whole thing. And if anyone thinks it should be something else, their perception or their focus is in the wrong place. So with that, thank you and enjoy the rest of your afternoon. If it's cold by you, because it's cold by here, that's the Northeast. Go somewhere warm. But I'm not sure you'll find such an amazing program that the heart is warm, the winter's cold. Actually, with global warming, it's not that cold. With that, vote. I can't advocate enough. Vote, vote, and vote. Tell people to vote. Get people to vote. People should vote. I'm not telling you who. I wish I could. Anyway, have a good one.
Thank you, everyone. Thank you for taking the time to meet us, and we're excited to see you on interview day.